Welcome back, ladies and gentlemen. Since we are emergency doctors, we have to reduce the door to needle time. So we are going to start the session a bit early. So it is my privilege to welcome you to this much anticipated plenary session. Today, we delve into one of the most pressing and debated topics in modern medicine, stroke thrombolysis. To guide us through this captivating topic, to do or not to do, stroke thrombolysis panacea, we are honored to have Dr. Gamini Pathirana with us today. Dr. Gamini Pathirana is an esteemed consultant, neurologist, celebrated for his expertise in stroke medicine with countless years of experience, currently contributing his expertise at National Hospital Sri Lanka in stroke medicine, neuropalliative care, and neuro-ophthalmology. Sir is the current president of National Stroke Association Sri Lanka and also past president of Sri Lankan Neurologist. Without further ado, let us welcome Dr. Gamini Pathirana to the stage to provide invaluable clarity and insight on the topic. Over to you, sir.
Good afternoon. Let me at the outset thank the Sri Lanka College of Emergency Physicians for inviting me to deliver this plenary lecture. Within the next 20 minutes, what I'm planning to do is to discuss about stroke, acute stroke care, and then take you through some of the key concepts of acute stroke management. And finally, because whenever I deliver this talk, there are so much of questions flowing into me. If you have any questions, we'll have interactive sessions to clarify those areas. So stroke, by definition, is acute neurological deficit where site of lesion is in the central nervous system, that's brain or spinal cord, or retina or optic nerve. And stroke is very common, and it's a disabling condition. And 90% of the stroke patients, stroke victims, had 10 preventable risk factors. And 1 in 4 individuals in the society is likely to suffer a stroke during their lifetime. And the most important and only effective way of not having a stroke is prevention. And secondly, for last couple of decades, we have the availability of acute care, where you can try and reduce the disability. The problem with stroke is mostly disability. The abilities that you have, in a short while, you will see that it's not there. You will not be able to speak and walk, and you can't do anything. So it's a disease causes suffering to human beings, and stroke burden is much felt in the low and middle income countries like ours. In the Asia, the burden is so much, and this has a big impact on the economy also. We are already having a problem with stroke. With that definition, we know stroke is of 2 types, ischemic and hemorrhagic. Ischemic ones account for a large majority, about 85%. Sri Lanka, we see actually hemorrhagic ones little more than what we used to hear, about 20%. And in both conditions are caused by uncontrolled risk factors, mostly the high blood pressure. And when you block an artery, I'm just trying to concentrate on ischemic stroke for the next few minutes. When you block an artery supplying blood to the brain, immediately the whole area becomes dysfunctional. But there are 3 arteries supplying on each side, anterior cerebral, middle cerebral, and the posterior cerebral. The common artery that gets affected is the middle cerebral artery. The moment you block the middle cerebral artery, the whole area becomes dysfunctional. The middle of the territory supplied by the middle cerebral artery suffers most. Surrounding area suffer less because there is collateral supply from the adjoining arteries. So the moment the artery is blocked, the middle area dies. That's the core. And the rest of the area, surrounding area, die slowly. So the rest of the area which is dying slowly, where if you unblock the block that was happening, probably there is a chance that you can salvage that area. So this salvageable brain tissue, which is known as ischemic penumbra, is a cornerstone for emergency care. After understanding this, that is the cornerstone, that's the main goal of having emergency care, is to salvage the penumbra. That is why we are looking at door-to-needle time and try and get the patient fast to hospital and try and work them up and then do thrombolysis, thrombectomy and many other things, try to salvage penumbra. So every emergency step is geared towards salvaging penumbra. Unfortunately, I didn't have much slides, so I had to keep talking, so you can probably listen to me. So until 1995, we didn't have a drug to dissolve the clot. But cardiologists, thank God, they were having a drug which was, they were thrombolizing. The same pathology happening in the heart, they were thrombolizing, but we didn't have a medication, a clot busting agent for acute ischemic stroke. A lot of trials going on. Because brain is softer than the heart, it tends to bleed inside. The moment you unblock or the moment you reperfuse the artery, it tends to bleed into the brain. So initial trials didn't succeed. In 1995, we had the first agent appearing, that was recombinant tissue plasminogen activator, inhibitor. In 1995, it was proved beyond doubt that within first 3 hours, if you deliver this agent to selected crowd, according to the inclusion-exclusion criteria in the NINS trial, you can produce a good result. The result, what we say to the patient when we do thrombolysis, when you get the consent, is we say, out of 100 patients who get this agent, 13 patients completely get better. They completely disappear. The hemiplegia completely goes off. And another 19 patients, 19, improves from their disability. And large majority of patients remains unchanged. And 2% get worse and 1% die. This is what we tell to the patient when you are trying to get the consent. Would you like to have it? Uh, 3% gets worse, 2% gets worse, and 1% going to die. But when you look at the data, we know this 3% who are having bad outcome, anyway they're going to be having bad outcome. So we made up our mind, yes, this is a positive result, we must practice it. This was in 1995, world over, this was a good result. So there was so much of propaganda going on. If you have a stroke, now come to the hospital very fast. We have an agent. So throughout the world at the moment, thrombolizing acute stroke patient is a standard practice. It is a standard practice. Until for few years, people thought maybe there is penumbra available still beyond 3 hours. Maybe we can thrombolize still longer than 3 hours. And there was another trial happening in 2005, that was ECAST 3, 2008. That was also same trial design, but the recruitment was within 3 to 4.5 hour window. And that also proved beyond doubt that it has positive result. So since then, since 2008, world over, acute stroke is being worked up, ischemic strokes. For thrombolysis, we use the same trial design in the emergency department. We have inclusion criteria, we have exclusion criteria, and CT criteria. We go through all of them. We have a checklist to check them. So those who qualify will receive the thrombolysis. And this is a trial proven, evidence proven treatment. You know, when you give salbutamol inhalation for acute asthma, they improve. But here, in this agent, when you give it, we don't expect next day the patient to improve. The result that you are expecting is what I just told you a while ago. So we are not waiting for the result, whether it's get worse, whether it's improving or remains change. We don't mind. We just deliver the agent because it has evidence to give this agent according to the trial. Now, what we do, I'm just going to go through what we do when we're doing thrombolysis. Usually all acute strokes we are invited them to come to hospital as fast as possible, and world over the mnemonic in English is available to recognize stroke at home. All of you probably know this. FAST, F stand for face, ask the patient to smile. And if the mouth goes to one side, that means maybe a sign of stroke. A stand for arms, ask the patient to raise the arms. If one arm does not go up, maybe there's weakness on one arm. And S stand for speech, get the patient to speak. If there's a language deficit. So these are the 3 common symptoms of acute stroke. So FAS and T stand for time. Look at the time and note down the time, because when you reach the hospital, they will ask what the time was. And little later, they had B and E at the beginning. So B fast. B stand for balance and E stand for eye. That also commonly get affected. Your balance goes off and maybe your vision can get affected. You can get hemianopia, or you can have monocular visual loss. You lose vision in one eye when the optic nerve is infarcted. So these are the common symptoms of acute stroke. So there's so much of propaganda going on, educating the public. And in Sri Lanka, we from Stroke Association, we were going throughout the country to educate public and hospitals and everywhere, educating them to come to hospital faster. Now we have a medication available, so come to hospital faster. So once the patient arrives to hospital, the first thing that we have to do is to diagnose stroke. The emergency physician or the doctors at the emergency must diagnose that this is a stroke. Stroke diagnosis is very easy. There's a definition to diagnose stroke. Acute focal neurological deficit, where when you examine, you think the site of lesion is in the central nervous system, or retina or optic nerve, that's also included. And it has happened all of a sudden. And the definition says of vascular etiology, but vascular etiology you cannot prove because you have to do an angiogram, which is not available immediately for us, bedside. So we go by sudden onset. So sudden onset, acute neurological deficit, where you think the site of lesion is in the central nervous system, or optic nerve or retina, that's adequate for you to diagnose stroke. Let me ask you a question. Sunday morning you are in the practice, a patient comes with saying, my arm is weak. What is the diagnosis? Can somebody shout out? Saturday night palsy. When you examine the patient, arm is like this. This is not coming from the central nervous system, it's a peripheral nervous system. So it's not a stroke. Sudden onset, focal neurological deficit, but this is peripheral nervous system. But if you think it's central nervous system, you need to have some understanding about neuroanatomy and neurology to pick this up. Site of lesion is generally by examination, we should be able to find out that this is a stroke. The vital part of emergency care is identifying this as a stroke. You can have stroke mimics coming to hospital also. When I was overseas training, a lady came in the middle of the night. There was a stroke call at 1 o'clock in the morning, so I ran to the emergency. This is a stroke call, so for thrombolysis. And when I asked the patient to say E, patient says E. But the way the patient was doing it, I understood this is not a true stroke. And I informed my boss, this is probably not true stroke, so we did not thrombolyze. Later on, we found that it was hysterical, and then so sometimes you can have neuroglycopenia mimicking stroke. You can have focal deficits coming due to hypoglycemia. You can also have seizure followed by Todd's paralysis. Sometimes after a seizure, you can have focal weakness. That also can mimic stroke. So stroke mimics also may appear in the emergency department. So diagnosing stroke is easy by the definition, but you have to be careful, making sure that they are not stroke mimics. Once you have done that, in the emergency department, they usually summon the neurology team, and we run there. My team run there. I also run behind them when I am available. Our neurology team is generally not like me. They are a little not overweight. So what we do, we go there. I have asked my team to run to the emergency, but after you reach there, be calm and listen to the story, leisurely, take your time, and you make a diagnosis of stroke. Once you make a diagnosis of stroke, that is first inclusion criteria for thrombolysis. Second inclusion criteria is patient arrives within the window of 4.5 hours. You have to ask when this happened and whether the patient is within the 4.5 hour window. Thirdly, patient must be more than 18 years old. And up to 4.5 hours, usually we thrombolyze, and up to 6 hours in Sri Lanka and Colombo, we do thrombectomy also. But if you go through the evidence, we can do thrombectomy up to 24 hours. There was a landmark trial happened in 2018. There were two trials. One is DAWN, D-A-W-N. The other one was DIFFUSE 3. These two trials proves beyond doubt that thrombectomy can go on up to 24 hours, but you need a lot of imaging techniques to prove that there is penumbra available in those patients. So we have 3 teams working together in the emergency department, the emergency physicians and the neurology team, and interventional radiologist also just close to them, looking after these patients. So once inclusion criteria are there, this patient is okay from that point, and we go to the, these are the inclusion criteria. So we have a clear clinical diagnosis of stroke, and patient presence within 4.5 hours, and age is more than 18 years. Then we have to look at exclusion criteria also. Before that, now clear diagnosis of stroke is necessary for thrombolysis because RTPA, the agent that we use, once you use it, there is a possible danger of having a hemorrhage inside the brain because this is a thrombolytic agent. It's not a drug like salbutamol inhalation. It's little adverse effects also there. You have to be careful. So subtle neurological deficit, non-disabling deficit, we are reluctant to give. That is why we look at the stroke deficit in the patient by a score called NIHS score. And if number is less than 5, we are reluctant to thrombolyze. Though we say number is less than 5, we are reluctant to thrombolyze, that particular number patient can have disabling one symptom, maybe the speech is gone. That is why I listed in the below. Even though the total number is less than 5, they may have one symptom which is significant. The speech, maybe the right arm, more important functions may be affected. So hemianopia, so those cases we tend to thrombolyze though the number was less than 5. And so with less than 4.5 hours, the patient must have a non-contrast CT scan to rule out hemorrhage. Clinically, we have diagnosed stroke, and hemorrhage can be ruled out by a non-contrast CT scan done immediately because hemorrhage is immediately shown up on the CT scan, and that proves that what you are having is ischemic stroke. We don't want to see the infarct on the CT scan. Infarct in the CT scan is not seen in the first day, first 24 hours. So CT scan is actually done to rule out hemorrhage. And first 6 hours is an early window for us for thrombectomy. More than 4.5 hours we do thrombectomy. So first 6 hours patients are chosen by CT angiogram, and the late window we choose them by CT perfusion or MRI scans. Whether we can thrombolyze patients less than 18 years, there was a trial done called thrombolysis in pediatric stroke, TIPS trial. This trial halted halfway through because the recruitment was not adequate. So we don't know the answer, but it's case by case, some patients are getting thrombolysis in pediatric adolescence age also. Once you have got the inclusion criteria, there's a list of exclusion criteria. My doctor will be checking one by one. Those are all causes where you can have tendency to bleed, where there's acute hemorrhage in the CT scan, history of previous intracranial hemorrhage, severe head trauma. This list goes on. What we do, we sit with the bystander and check all of them, whether none of the bleeding problems are there, recent surgeries, recent head injuries, recent major surgeries, and use of anticoagulants. So there's a whole list of that we go through. Now, this I thought to do or not to do stroke thrombolysis, I thought we will describe how we do it, and to do or not to do is selected by case. So we have a big list of exclusion criteria time gone by, but as new imaging techniques are coming in, the number of exclusion criteria have come down actually. Early trials said more than 80 years we don't thrombolyze, but now it's relaxed. We can thrombolyze more than 80 also. And severe stroke, more than 25, we don't thrombolyze. NIHS score more than 25 because the risk of hemorrhage is high. But that also is now shrinking. We can thrombolyze carefully selected cases. And improving symptoms. You have worked up the case in the emergency and we are about to give the drug, patient is now improving. Those cases also we tend to give because now the agent becoming more and more safe. And recent myocardial infarction was there in the exclusion list, which is also now becoming cautious. They are not ruled out, but they are relative contraindications now. And sometimes when you have a seizure at the onset of the stroke, we tend not to thrombolyze because seizures can follow with a weakness, seizure-related weakness, which is called Todd's paralysis. And sometimes we find it difficult to differentiate whether it's a stroke or Todd's paralysis. But now we have better technique to differentiate them, so that's also not there in the absolute contraindication, which moved to relative contraindications. Same with, there's a big list going on. I think we have 1 minute. And the reason why the exclusion criteria have come less and less is because of advanced imaging techniques and expanded time windows, and more careful assessment and more data available. So I think I have summarized how we do the stroke thrombolysis. Within short period, I think we cannot talk too much about it, but within the last minute, I will wind up from here and allow any questions that you have to clarify. Here, Mike. You can shout. Yes. Now, recently, tenecteplase has come as a newer kid on the block, and we are actually currently using the tenecteplase in National Hospital and world over. We have moved to tenecteplase because we have seen advantages of tenecteplase: cost, bleeding tendency, and easy administration. It's just a bolus, and also this is more fibrin specific. Not like RTPA. RTPA will attack the fibrin as well as the wall, so they tend to bleeding, and bleeding chances are lower with tenecteplase. And we had to have a little bit of struggling with the cardiologist to have it in Colombo, but ultimately we won and we are having it with us. So we have 40 milligram vials, and we can use it for 2 patients, so it's cost effective also. So we use tenecteplase now for thrombolysis.
Thank you very much, sir. May I invite you to remain on the stage to receive a token of appreciation. I would like to invite Dr. Thanuja Darshani, Consultant Emergency Physician from Sri Jayawardenepura General Hospital, to hand over the token. Thank you, madam. Thank you, sir. Welcome to Golden Hour for the Silver Years, Managing Elderly Trauma, where we will discuss the challenges and breakthroughs in managing elderly trauma.
The golden hour represents a crucial period during which prompt and decisive intervention can significantly influence patient outcomes, often delineating the boundary between survival and mortality.
Let's rethink, refine, and revolutionize trauma care for this vulnerable yet resilient group. To lead us through this fascinating and critical discussion, we are joined by Dr. Vihara Dassanayake, Senior Lecturer in Anesthesiology and Consultant Anesthetist, Department of Anesthesiology and Critical Care, Faculty of Medicine, University of Colombo. Madam, I would like to come and have a seat on the main stage. And Dr. Keerthi Abeyjeewa, Senior Consultant General Surgeon and Country Chair for ATLS in Sri Lanka. Dr. Sithira Senevirathne, Consultant Geriatrician, National Hospital of Sri Lanka, former Fellow in Geriatric and Perioperative Medicine in Oxford University. And last but not least, Dr. Lakmi Hannadige, Consultant Emergency Physician, Accident and Orthopedic Service, National Hospital, Sri Lanka.
And today for this session, we have two moderators, Dr. Jagat Vijayratna, Consultant Emergency Physician, National Hospital Galle, and Dr. Kanchana Bandara, Senior Registrar in Emergency Medicine.
Join me in welcoming the speakers to share their invaluable insight.
Good afternoon, everybody. So, welcome to the symposium number 4. So, as mentioned earlier, here we are going to discuss a geriatric trauma case. So, you all know that given the increasing elderly population in Sri Lanka, this will be a timely, relevant, and an important topic for you, everybody. Right? So, this will be a case discussion, but we are planning to set aside a few minutes at the end for to take questions from the audience. Right? Kanchana, shall we start the case?
Yes, sir. Let me introduce Mr. A, 75-year-old retired accountant from Galle, and he lives alone with occasional visits by a caregiver, and he was found by a neighbor lying on the floor at home. An estimated time lying on the floor is 6 hours before discovery. And in past medical history, he is a diagnosed patient with atrial fibrillation, for which he is on dabigatran 110 mg twice daily, and also he had a history of acute coronary syndrome, hypertension, osteoporosis, and mild dementia. And he is on several medications for this medical condition. And also, his caregiver reported that his confusion state was increasing and he was disoriented over past few days. And currently he complains of severe pain in his left hip and inability to move the left lower limb. And he also reports mild headache, chest pain, and abdominal pain.
Okay, so shall we move to the first question for the panel? So I'll start with our geriatrician, Sithira. Dr. Sithira, how common are falls in elderly in general? Can you?
So, falls are very common actually in elderly, so it's recognized as one of the geriatric giants. So I'm sure you are seeing a lot of falls in day-to-day practice, but we don't have much local data. If you look at the global data, actually falls are like increasingly prevalent when you get older. So if you look at the population more than 65 years, so generally it says 1/3 of all older people more than 65 years falls during 1 year time. And if you're more than 80, half of the population will fall within 1 year. So it's quite common. And these falls result in a lot of injuries, as you know, and like carries high degree of mortality. So it says like every 45 seconds around the globe, one old adult die because of a fall. So it's a quite common thing in old age.
Okay, Sithira, good to know that. So, Sithira, what factors would influence falls? I mean, when you consider falls in elderly?
Yeah, actually, classically we divide the falls risk factors into intrinsic factors and the extrinsic or the environmental factors and the behavioral or situational factors. And so when someone comes with a fall, so my general approach would be first see whether this is due to a acute medical problem, like whether it could be a seizure, whether it could be a syncope, myocardial infarction, whether it's a hypoglycemia, or there's an identifiable medical problem. So said that, most of the falls in elderly are multifactorial, right? So we are seeing a lot of multifactorial geriatric falls, all right? So looking at the risk factors, so if you look at the intrinsic risk factors, these could be visual impairment, hearing impairment, and like problems with your balance organs, and it could be mobility and balance problems like sarcopenia, reduced muscle strength due to sarcopenia. It could be peripheral neuropathy and postural hypotension. There are a lot of intrinsic medical problems that can give rise to falls, and not to forget about medications. So polypharmacy, as you know, like polypharmacy by definition is like using 5 or more medications concurrently is independently associated with falls. So especially drugs like antihypertensives, if you're on multiple blood pressure medications, you are more prone to get postural hypertension, and hypoglycemic agents, especially sedatives, and the other problems like cognitive impairment, urinary incontinence are like independently associated with falls. And if you look at the extrinsic risk factors, now, so extrinsic risk factors could be like the risk factors in your home or you are outside the home in your community. So if you look at the risk factors, environmental risk factors, things like slippery floors and poor lighting in your home environment, things like, like older people's houses are sometimes filled with clutter and there are like wires going all over the place. And so most of our home environments are actually full of false risk factors. And so they interact with the intrinsic risk factors. And look at the situational or behavioral risk factors. Like, so if you have a fall, you have high risk of falling again. So that's one of the major risk factors. And the people with falls, they develop something called fear of falling. Yeah, I'm sure you have encountered this. So this leads to a vicious cycle where the people will not move, and it will lead to much more disability and increased risk of falling. So it's kind of a vicious cycle. So it's the behavior risk factor that will increase the risk of falling. And also risk-taking behaviors, like people with poor balance, if they are climbing ladders, so that carries risk of falling. And things like alcohol intake, and like if someone is having urgency rushing to toilet. So there are a lot of behavioral risk factors as well. So when you approach to a patient with falls, most of these patients carries not only one risk factor, they carry multiple risk factors. So some of them are intrinsic, some of them are extrinsic, some of them are situational. So the interaction of multiple risk factors will result in a fall. So in studies, they have shown like if you have one risk factor, let's say you have 20% risk of falling. If you have 2, it increases up to 40. If you have 4, you have 80% risk of falling. So likewise, more risk factors you have, more risk you are going to fall.
Thank you, Dr. Sithira, for that comprehensive answer. So, Dr. Abeyjeewa, as a general surgeon, what would be your approach in evaluating a geriatric trauma patient?
So, as in any patient who comes to the emergency after trauma, you would do what we need to do is to exclude all the life-threatening injuries. Especially the primary survey is aimed at excluding the immediate life-threatening injuries. So, when the patient comes in, you have to assume that there are other injuries which are not apparent at that point. So you do what we call like a generic protocol, starting from what the famous ABCDE. So you first of all immobilize the patient on a spinal board, use the collar and the log and the straps, and then you are happy. Once that your C-spine and the rest of the spine is immobilized, you go on to check the airway. So use oxygen 15 liters, high flow, and then open the airway, suck out secretions, and look for any dentures or secretions which are there, and to remove them, and may have to use airway maneuvers like jaw thrust or the chin lift. And if that helps, sometimes you may use a oral airway and then keep oxygen. But sometimes, if by this time you should have connected the patient to monitoring, saturation, ECG, blood pressure and pulse monitoring. So if they are not happy with the saturations and the pulse oximetry, then you may have to intubate, even using sometimes surgical airways. So that's how you deal with A. Then of course you go on to B, breathing. Quickly look at the neck for any tracheal deviation, and then neck veins distension. Then look at the chest movements, percuss and auscultate. So those 5 things you need to do with chest, and most of the things in the chest can be diagnosed with that. If there's any life-threatening injury, you deal with it. Maybe an intercostal drainage tube. you also exclude, listen to the heart to exclude a cardiac tamponade at that point, and then you go on to do the circulation part. So circulation, there are two arms of circulatory management. One is to stop the bleed, other is to replenish the circulation. So stop the bleed depends on whether it's a limb, junctional bleed or a torsal bleed. So in limb bleeds, you can stop the bleed with direct pressure, compression bandage, or even with a tourniquet. Junctional bleeds, you may have to use pressure or packing. Of course, the torsal bleeds, you may need to do a fast to diagnose them, and depending on the situation of the patient, you may the patient may need to sometimes go for urgent surgery as well. The other arm is the replacement of the fluids. So you have to use 14 to 16 gauge needles in the antecubital fossa, two cannulae, take bloods, investigations, full blood count, group cross match, electrolytes, creatinines, the basic biochemistry, as well as if it is pertinent, amylase level, alcohol levels, and beta HCG levels, and VBG, and then start your IV infusion of preferably warm Hartmann solution. At this given point, we recommend to give 1 liter in the ATLS protocol, up to 1 liter. In an elderly person, we have to be careful because, as we know, they may be having comorbid factors. So you give aliquots of 250 and look for the response, and then from there take on whether the patient needs blood transfusion or not. You may even have to get the massive transfusion protocol activated. Then that is the circulation, and then you go on to the D. After you have done the D, if you are happy with the C, then the three things you need to check quickly: the pupils, the reactivity and the size of the pupils, the GCS, and the gross movement of all 4 limbs. Those are the things you have to check in a disability. You then go on to E. You expose the patient and look for any injuries. Do log roll at that point. Look for the spinal injuries, any injuries at the back, any other things that you have missed. Maybe you may need to do a rectal examination if there's a spinal injury or there's bleed from the rectum. And then, of course, you need to warm the patient, at least cover the patient, or if you have equipment, to use warming equipment. So once you've done the A, B, C, D, E, you should have, if the patient is unstable at any point, of course you go on to start with the AB reassessment. Then the things that, the adjuncts that you use are whenever relevant, the NG tubes, catheters, medications like antibiotics, toxoid, tranexamic acid, painkillers, and then from there onwards you need to decide what you are going to do with the patient, whether it's in your capability or whether you need to be transferred out of your hospital. So that's the protocol of the ATLS in any injured patient, including the geriatric patients.
Thank you, Dr. Abeyjeewa, for that detailed answer. We have another question for you. And what injuries do you specifically look for in elderly falls?
Falls, I mean, in elderly, the difference is you can have trivial, fall on the surface and have significant injuries. Even in this patient, probably has a neck of femur fracture, if that is the case. So fractures wise, in elderly, what are common is neck of femur, very common, distal radial, and also proximal femur, proximal humerus fracture. Then you can have axial fractures like wedge fractures of the lumbar spine with not so significant trauma. And non-fractures, you can have scalp lacerations, then rib fractures, because ribs are very non-resilient. They are very rigid, and you can break them with minimal force, and that can bleed, especially if they are on medications. Abdominal injuries, because they can't they can't break the fall, so they will knock on whatever around them, having significant injuries compared to a younger person.
Right. Sithira, do you have anything else to add? this particularly this patient? What did
Of course, you have to think of rhabdomyolysis as well, because commonest cause of rhabdomyolysis in elderly is falls and injuries. So you have to exclude that as well.
Thank you, sir. Right, so Kanchan, shall we proceed with the initial assessment findings?
Yes, we approach and assess this patient according to ATLS protocol. These are the vital signs on arrival. His airway is patent and no cervical spinal tenderness and no external signs of bleeding. He's little bit tachypneic, respiratory rate around 24 per minute, and there's a significant tenderness left side lower chest wall. And on auscultation, there are fine bibasal crepitations. His oxygen saturation is 91 on room air. His mucous membranes are dry and skin turgor is reduced, but peripheries are warm. And he's little bit tachycardic and pulse rate around 110, irregular and moderate volume pulse, and blood pressure is 110/60. And disability-wise, he is confused, and GCS is 13 out of 15, and blood sugar is 84. And his body temperature is normal, and there's a mild abdominal tenderness. And his left leg shortened and externally rotated, and there's a mild swelling around the left hip area. And also there's a redness on sacral and buttock areas, suggest early signs of pressure-related changes, and his bladder is palpable. So these are the findings of EFAST. The EFAST is negative for prefluid in the abdomen, but in the lungs there are small bilateral pleural effusions with few bibasal B lines, but no pneumothorax and no pericardial effusion. This is his X-ray. The X-ray shows bilateral small pleural effusions and no pneumothorax or no obvious rib fractures. And ECG also taken, ECG shows atrial fibrillation.
Okay, so Dr. Lakmi, if these patients come to your ED with these initial assessment findings and investigations, how would you stabilize this patient?
Yes, Jagat. So, initial stabilization of an elderly trauma patient, we can still use the protocol that we use for a young adult patient, the CABCD methodology. But the interpretation of their vital parameters, and when we determine the severity of injuries, we have to take into consideration the effect of age, the comorbidities and the drugs on their organ systems. So take C-spine. So they have osteoporosis and they have overall like low bone density. So they are more prone to get vertebral fractures. So they need a C-collar early. But on the other hand, prolonged application of C-collar is associated with significant morbidity in elderly patients. So the goal should be to suspect C-spine injuries early, but clear the C-spine as quickly as possible and get them out of the C-collar as soon as possible. Then let's move on to the airway. So this patient's airway is patent, which is great. But in elderly population, their protective reflexes are significantly lost. And also, over time, their joints become arthritic. So TM joint is just another joint. So you can have like restricted mouth opening. And also, many of them have dentures. So dentures are nice to get a good framework for the face. So dentures are your friend when you want to bag a patient, but they are enemy when you want to intubate a patient. So if the dentures are not obstructing your airway, under supervision, you can keep them if the patient requires bag, but as soon as you are ready to go with the laryngoscope, you need to take that out. So that's with the airway. So the bottom line is that elderly patients, trauma patients' airway is considered a difficult airway until proven otherwise, especially in the presence of C-spine injuries. So let's look at the breathing. Now this patient is slightly tachypneic and he's got an element of heart failure. but luckily he doesn't have pneumothorax or hemothorax. So I would start with oxygen via face mask. But the things that we have to remember about breathing in elderly population is that they have less reserve and their lungs are stiff and they could have chronic lung pathologies. So they would desaturate quickly even with a very minor insult. So you have to stay on top of that. So this is especially important, like contrast to a young adult trauma patient who would do fine with intubation for whatever the reason, like agitation. These elderly patients, elderly trauma patients, would not do well if they are intubated. So especially when you are dealing with an elderly trauma patient, if there is no strong indication to intubate a patient, like severe respiratory distress or deteriorating GCS, you really want to avoid intubation as much as possible. So that's with the breathing. So when it comes to circulation, so this patient is slightly tachycardic with a seemingly normal blood pressure and a negative fast scan. And he's also dehydrated. So the challenge is, in elderly population, you should be able to identify the early signs of shock. So that's why in trauma we use shock index. So shock index is heart rate divided by the systolic blood pressure. So in an elderly patient, so they have a altered, reduced physiological tachy response to bleeding and stress due to their, again, age, comorbidities, the drugs they are on. All their physiological responses are blunted. So suppose now the shock index comes more than 1, or the shock index is positive for this patient. So you can rule in shock in an elderly patient using shock index, but suppose there's a patient who is on beta blockers, and this patient is bleeding, but this patient could have falsely reduced heart rate because he's on beta blockers. And then his shock index will also become falsely negative. But that doesn't rule out shock in this patient. So a negative shock index or an age-adjusted shock index, a negative shock index, should not be used to rule out shock in elderly trauma patients. And the other important thing is, these elderly patients are volume depleted, like fluid depleted at baseline. They could be on diuretics. So unlike in young adult trauma patients where we encourage early use of blood and blood products over crystalloids, it is reasonable to give small fluid boluses to these elderly patients coming with trauma. So, but at the same time, although they are fluid depleted, they are also very sensitive to fluid overload. So that is why we need to be judicious and thoughtful when we are giving fluid, and we need to use like bedside ultrasound scan, Pocused, to guide your fluid resuscitation. So that is the challenge with circulation in these patients. Then moving on to disability, so his disease is 13. So I would order an urgent CT head for this patient. So the problem with disability is that these elderly patients have they have cerebral atrophy, and some of them may be on oral anticoagulants like our patient. So they are more prone to get traumatic brain injury even with a trivial fall, even with a trivial head impact. But on the other hand, because they have cerebral atrophy, they have enough room in the skull. So they will present late. Their neurological manifestations will be late until the traumatic brain injury is significant. So you really need to be cautious and aware about that possibility. And then the environment and exposure, I would make sure the patient is warm and not hypothermic, and take the backboard or the spinal board as soon as possible. So this is the, my approach to initial stabilization of the patient. And also, like Sithira said, their falls are mostly secondary to some other medical condition. So we have to actively look for that as well.
Thank you, Dr. Lakmi, for that detailed answer. So, Kanchana, did you find anything positive in the secondary survey?
Yes, because he complained of severe left side hip joint pain, we do focus assessment of left lower limb. These are our findings. Left lower limb is shortened and externally rotated, and there's a significant tenderness over left hip and groin area, and the pain increases with minimal movements or attempted to reposition of the legs, and pain score is according to visual analog scale is 5 out of 10, and distal pulses are present.
Okay, okay, Dr. Abeyjeewa. So, as a surgeon, how would you diagnose a neck of femur fracture?
Neck of femurs, as commonly we learn from medical student days as well, looking at it, some of the neck of femur fractures can be identified because it's externally rotated, because under post action of the psoas muscles, so shortened as well. But sometimes it's not there all the time, especially undisplaced fractures. So we may have to do the basic radiographs. One of the radiographs you have to do in the primary survey is the pelvis AP. So over 90% of neck of femurs can be diagnosed with a pelvic AP X-ray. So that would be the way of diagnosing it. So sometimes, if you're not very sure, the orthopedic surgeons may request CT scans later on when the patient is stable and out of life-threatening injuries to assess and maybe reconstruct sometimes the acetabular and so on.
Okay, thank you, sir. So, when considering neck of femur fractures in elderly, what factors would affect the treatment approach, especially elderly?
Yeah, treatment for neck of femur is fixing, but here when it comes to elderly, there are other issues that come in. If you don't fix the fracture, they will be sort of bedridden for 2 to 3 months, and that sometimes may be the downfall and the end of the patient as well. So we try to get them fixed early and release them back to their normal lifestyle. But here again, you have to consider a few factors like their pre-fall lifestyle, whether they were mobile or whether they are just bedridden and that sort of patients. If they have been bedridden beforehand, sort of subjecting them for a major surgeries, you have to think twice. But of course, if they have been mobile, despite their age is basically the biological age that you should take, not the chronological age. Sometimes a 90-year-old person will be quite fit and driving the car, whereas a 70-year-old person will be bed-bound or chair-bound. So you have to take their chronological, biological age and their pre-fall status. Also, the type of fracture will have some bearing on whether they are going to fix it or not. Minimally, sometimes they are just cracks, they are not displaced. So some of them can be managed without surgery, impacted fractures, so on. But if they are displaced and associated with acetabular fractures, then of course they may have to have surgery. But of course you have to risk the benefit of the surgery against the risk of anesthesia and the surgery itself.
Dr. Sithira, so talking about geriatric pain assessment, so do you think the cognitive assessment can influence the patient's pain assessment, and are we undertreating pain in elderly?
Yes, actually it's quite important to assess pain. I think pain is something we don't assess as a vital sign and which should be assessed quite regularly. It's a very unpleasant experience and something which is treatable as well. So how does cognitive impairment influence pain? So if someone is cognitively impaired, as in this case, this patient was diagnosed with dementia, and if you have kind of a acute neck of femur fracture, you can have delirium on top of dementia. So so if you ask whether with a scale like visual analog scale, patient might not be able to correctly like tell the intensity of the pain. So that's a drawback of the traditional pain scales. And so the other thing is, like, sometimes we use the character of pain to look for the underlying diagnosis. For example, if you have chest injuries, the patient you can ask whether you have pleuritic type chest pain, And the dementia patients in delirium might not be able to characterize the pain. So that's a challenge as well. So we move from traditional pain scales to, we use non-verbal cues to see whether the patient is in pain. So some of the scales we can use are like, there's a scale called Von Baker scale, where you look at the patient's face and look at the patient's facial expressions. This was adapted from pediatrics actually, and can use that to see and grade patient's pain, like whether it's mild pain, moderate pain, or severe pain. And looking at the other pain scales, one of the most commonly used pain scales, especially in ED, is like pain aid. That's called pain assessment in advanced dementia. So there actually what we are looking at is patients' facial expressions again, breathing pattern, their negative vocalizations and their behavior, and then whether we can console them. So that kind of non-verbal cues we can use to see whether the patient is uncomfortable, whether they are in pain. So these patients might not ask for pain relief because they are obviously confused. So you have to go and regularly assess for pain, and if they are in pain, so you have to optimize the analgesics. So as you said, if you don't treat pain properly, the delirium can get worse. So post-operative outcomes can get worse. So it has been shown like uncontrolled pain, delirium is associated with more mortality. So this is something which we should assess quite regularly. And as you said, it's quite challenging. We have to use specific details, specific methods to assess pain in cognitive impaired patients.
Okay, thank you, Dr. Sithira. So regarding the management of pain, so the best person to answer is Dr. Vihara. So what strategies can we use to safely and effectively manage pain in this patient? What do you think?
Thank you for that question, Jagat. So from what Sithira said, it's pretty obvious that a patient, an elderly especially, who has had a fall, managing pain becomes very important because, as you all know, consequences of pain in an elderly is not going to be good. And sometimes in terms of trying to get them for some imaging, some movement of the limb, you obviously, if you do not provide any pain relief, it's not going to facilitate the procedure. So the answer is very straightforward. It's multimodal. When we mean multimodal, what comes in it? So there's systemic drugs, and then there is the regionals. When I mean regionals, I'm referring to nerve blocks. And I think I'd start with the latter because there's lots of evidence out there from systematic reviews and randomized controlled trials that using nerve blocks in the elderly, especially in fracture neck or femur, is what they highly recommend and suggest. Now, what's the reason for that? If you look at the evidence again, number one, in a busy emergency department, it's not difficult to do a nerve block. A simple one is fascia iliaca. I'm sure if you read the literature around fracture neck of femur and pain management, that's number one that's going to come up. It's single shot. If you want, if you have infusion catheters, you can actually put an indwelling catheter and give an infusion. That is also possible. Can it be repeated? Yes, it can in 6 hours, provided there's a lapse of 6 hours between the first block and if you want to repeat it again. The thirdly, in this patient especially, who has been on dabigatran, is it a contraindication? No, it isn't. So you can actually, with a lot of confidence, insert this catheter or give a single shot, even in a patient with dabigatran, because it is not a contraindication for patients on anticoagulation. Fourthly, with or without ultrasonography, you can actually do a fascia iliaca block. It's a very easy, short learning curve. You can easily give it. So there's a lot to say. Go ahead with a regional block. And I think the most important thing is from what you've heard so far, because with the diminished physiological reserves, a lot of comorbidities, you would try to go for what is called opioid-sparing analgesia. So you can reduce the opioid consumption. And also, you know that most of these patients are delirious, especially after these falls. They have renal impairments. So you're worried about giving a lot of, opioids. But that does not mean that you cannot give them. So out of nerve blocks, fascia iliaca takes precedence, but of course you can do femoral nerve blocks. There's this new kind of group of blocks called the PENG blocks, which has come in, the pericapsular nerve group blocks. So all that are options. This can be supplemented with oral paracetamol, maybe 1 gram 6 hourly, which is a regular dose, which can be either oral or IV. And you can, of course, if there's no contraindication, supplement with that with tramadol, gabapentin, and so on. You do not really deprive them of opioids if it's really necessary, but sadly, in our part of the world, we don't have liquid or oral morphine, but in the West, you get a lot of oral morph, which is given as a part and parcel of pain management in these patients. But what we're going to have a very high threshold, or we try to avoid, is NSAIDs for obvious reasons. And there is a guideline, or rather a recommendation by the National Institute for Clinical Health and Excellence in the UK, where they say when the patient comes, you assess pain, you give whatever the regional or your systemic drugs that you want, reassess in 30 minutes, and then hourly until the pain settles. So I think that's the answer to the strategies.
Thank you, Dr. Vihara. So we have another question. What important considerations you have to consider when administrating local blocks in
this patient? Yeah. So this is going to be quite challenging, because if you remember the history, he's not only elderly, but he's got dementia, he's confused, his GCS is 13. And I say you can actually give a nerve block. And we all know that you need patient cooperation for a nerve block. So this is actually quite challenging, number one. And number two, to explain to the patient, get the history from the patient, is equally challenging, like you heard from the earlier speakers. And it's also important to remember that you do not exceed the toxic or the maximum dose, because these are patients who have a reduced muscle mass, and for obvious reasons, they're very sensitive to local anesthetics. So we should be able to sort of calculate it accordingly, and also to make sure that you have all the resuscitation facilities, which includes the drugs and the help at hand when you're doing it. And I think one last point to add to that is whenever you do a regional block, we cannot do it on the wrong side. As you know, that's a never event. So therefore, you should be having checklists, and there is this concept or this thing where they have flyers all around saying stop before you block. So you've got to do that with the operator as well as the assistant. But again, in this particular patient, you cannot get the patient involved because he's confused. So you can't really go by him. So I think you should be able to probably go by the imaging and look at the records, make sure that you've sort of marked the site before you go ahead with it. So I think that's the answer to your question. Yeah?
Thank you very much, Dr. Vihara. So talking about the regional blocks in the ED, Dr. Lakmi, what challenges do you face when administrating local blocks in ED?
Yeah, so Dr. Vihara explained nicely the challenges that we face. So apart from the daily struggle in the ED, in a busy ED setup, I would categorize into 3 categories, like the challenges we face with geriatric patients. So pre-procedure, intra-procedure, and post-procedure. So for example, pre-procedure, obtaining the consent would be challenging due to cognitive impairment and then the low GCS. And then during the procedure, getting the patient to follow our instructions, being cooperative with the advice that we give is challenging. And post-procedure, because these patients are not, could have dementia, so they are not in a good mental status, so they might not really express their symptoms, or they won't be able to complain us if they develop symptoms and signs of toxicity. So they would need close monitoring in a ED. So I think these are the kind of challenges that we face in ED.
Thank you very much, Dr. Lakmi. So, Kanchana, what happened to the patient?
Yes, sir. A fascial block was successfully administered and pain was relieved. But 20 minutes after the regional block, a patient condition get worsened. And he's restless, agitated, and blood pressure drops to 90/60, and heart rate climbs 130, irregular and low volume, and oxygen saturation is with oxygen face mask is 93, and patient become increasingly pale and diaphoretic.
Okay, so Dr. Lakmi, this patient is deteriorating. So what are the likely causes for that?
So in the setting of trauma, if a patient suddenly deteriorates, my first DD would be hemorrhagic shock. Second and third will also be hemorrhagic shock. But this patient also had a nerve block. So I have to consider the possibility of local anesthetic toxicity as well. And then, of course, traumatic brain injury. So that would be my, main 3 DDs.
Thank you very much. So, Dr. Vihara, so Lakmi mentioned about local anesthetic toxicity. So, could you tell us how to identify and manage local anesthetic toxicity?
Yeah, so bearing in mind, like I said earlier, the elderly are basically sensitive to local anesthetics for a number of reasons, because they've got a reduced tissue mass, reduced adipose tissue, and they do not have the ability to vasoconstrict, and they have multiple comorbidities. So considering all this, the question is, how do you suspect? So as we all know, it's mainly cardiovascular and central nervous system effects that's going to come up first. And if you look at the CNS effect, they have what is called a biphasic response. So they have initially an excitation followed by depression. So what would be the excitatory signs that one would find? They'll complain of lightheadedness, they'll be agitated, they'll be disordered like sensorium and mentation, and of course leading on to tonic-clonic convulsions, and coma. In terms of cardiovascular, it's mainly because the local anesthetics act on the conduction pathway. They actually directly affect the SA node, so it's pretty obvious that they're going to come up with bradycardia and even leading to asystole. But of course, there are ventricular tachyarrhythmias also, which is there, can be a manifestation. So mainly that is how you would identify local anesthetic systemic toxicity in them.
And a bit about management?
Yeah. So going on to management, obviously it's supportive. So immediately what you would do is, as in anything ABC, so you support the airway, and if you need to secure the airway with endotracheal intubation. In terms of breathing, usually local anesthetic toxicity effects gets compounded in the presence of hypoxia and metabolic acidosis. So you have to give the highest concentration of oxygen, 100% if it's possible. If not, at least hyperventilate, because you can wash out the carbon dioxide and reduce that metabolic acidosis. Coming to circulation, obviously this patient hopefully has a cannula, but you can always get another cannula in, and if they are convulsing, you obviously have to treat the seizures. So that's quite common, that's very supportive. But I think what is important is specific management. And anywhere, even in a busy ED, if you're giving a local anesthetic block, you've got to have an antidote to treat it. And the antidote is 20% intralipid, which is a lipid emulsion, and there is an algorithm which we follow. So you need to give a 1.5 ml per kg. That's a stat dose, and you start on a 15 ml per kg per hour infusion. So I know it's not easy to remember all these numbers, so I think what you should be really having is a protocol which is there in your ED so that you follow it, and you can repeat those boluses twice and increase the infusion to 30 ml per kg per hour. But of course, you've got to monitor them, take the bloods later on, because they are more prone to things like pancreatitis. So if you give intralipids, you've got to monitor them very closely.
Thank you very much, Dr. Hara. So, Kandiah, can we proceed with the case?
Yes, sir, this is our reassessment. In reassessment, there are no signs of local anesthesia toxicity, but repeat past scan shows positive for free fluid in the abdomen, and blood pressure further drops 80/60, and heart rate climbs to 138.
Okay, so we have another problem. Dr. Lakmi, so what challenges of managing polytrauma patients? Positive fast scan.
Yeah, so this patient has suddenly deteriorated in his hemodynamics with a positive scan. So now his resuscitation priority is shifted towards stabilizing his circulation. So I would practice damage control resuscitation in this situation like in any other trauma patient, but keeping in mind the variations of their response to trauma, physiological response to trauma. So the goal is to prevent establishment of lethal diamond, that is acidosis, coagulopathy, hypocalcemia, and hypothermia. So, and also to think about reversal of anticoagulation. So doing that, so the resuscitation of the fluid management, again, like we have described before, so they need to have judicial and thoughtful fluid resuscitation, early use of blood and blood products, giving tranexamic acid. At the same time, we need to get the trauma surgical team involved early in the course of management to decide whether this patient needs damage control surgery versus the patient needs imaging prior to surgery. Having said that, if this patient continues to deteriorate despite all your measures, this elderly patient, so we have to think about and we have to start a discussion on palliation versus active resuscitation. Yeah.
Thank you, Lakmi. So another question for you. So this patient is on anticoagulant. So how do you manage trauma patients on anticoagulation?
Yeah. So the challenge in the setting of polytrauma, the challenge is to decide between whether to discontinue this drug for temporary versus reversal of the drug. So it's weighing the pros and cons, weighing between preventing bleeding versus thromboembolic event. So, I mean, it depends on the type of anticoagulation the patient is on and its relative half-life and the patient's renal function and also the level of drug in the patient's circulation in terms of coagulation test. So, this patient is on dabigatran. So, it's a direct oral anticoagulant. So, it is a thrombin, like a competitive thrombin inhibitor. So if the thrombin time is normal in this patient, that actually effectively excludes this patient's the drug effect on this patient's circulation. But if you take apixaban or rivaroxaban, if there is normal PT and APTT, we can't really exclude their effect on the circulation. So having said that, if there is a major bleed, and in the absence of the specific antidotes, we'll have to consider the other prohemostatics like prothrombin complex concentrations and FFP, obviously with the expert opinion from the hematology team. Yeah.
Thank you, Lakmi. So, Dr. Abeyjeewa, if surgeons are called to see this sort of patient with intra-abdominal bleeding, how would you manage as the patient as a general surgeon?
Yeah, thanks. I think I'm happy that surgeons have been called early. Trauma, hemorrhage is the commonest cause of preventable death. So you have to control hemorrhage, and we call the factor 14 the surgeon. You have to call them early. So if I've been called for this, so depending on the patient's hemodynamic status, if the patient is crashing despite resuscitation, the patient may have to be rushed to theatre, which for damage control surgery. So otherwise, if the patient is stable enough, we will, as I will echo what Lakshmi told earlier, we will replenish the circulation and using point of care coagulation testing as well, and maybe later on to do a CT scan, and some of the bleeds may need not go to theatre at all. So there are only few absolute indications for trauma laparotomy. One is clinically or radiological findings of bowel perforation, evisceration of abdominal contents, and other thing is the severe hemodynamic instability despite resuscitation with evidence of ongoing bleed. So I would balance the situation and take a decision accordingly.
Thank you, Dr. Abeyjeewa, for that descriptive answer. So, Dr. Vihara, if the surgeons decided to open this patient, how would you optimize an elderly patient?
Yeah, sadly, we don't have much time for optimization. So I think optimization and resuscitation and taking to theatre obviously, it goes hand in hand. So I think I'm not going to go deep into it because I think the fluids have been dealt quite extensively. So obviously, you've got to make sure that your patient is not overfilled or underfilled. And I will have a very low threshold, even within that little time that I have for the optimization, to get at least an intra-arterial blood pressure line in invasive monitoring, because that can give you a lot of information, as in cardiac output, the stroke volume, because it's very important that we use dynamic parameters to monitor how much of fluids. When I mean fluids, I'm not referring to just crystalloids, because it was stated that you've got to curtail the amount that you give, but the blood. So we can guide that by invasive monitoring. And if you have the bedside echo, that will give you an idea of the volume status as well as a global function. Other than that, well, obviously, you're going to you've got to have extra pair of hands. I would say more pairs, and inform the so it's a real multidisciplinary team involvement, isn't it? So we would actually get to the blood bank, because we need to pump as much as, the leak, the tap has to be closed. But Anything else? Yes, pain relief. I would not sort of not give that just because the patient is hypotensive, so we'll be cautious, but we'll do that and make sure that you prepare for, in terms of acid aspiration prophylaxis. They may be having high blood sugar, maybe diabetics, so we've got to get that on control and make sure just an ABG will give us a lot of information about the electrolytes. So make sure that the metabolic and the electrolyte parameters are normalized. But saying that, I won't have much time for this, so it's hand in hand. Yeah.
Thank you, Dr. Vihara. So, Dr. Kanchal, so do you have any other details
Yes,
regarding this patient?
while medical team is managing this patient, a neighbor came to the hospital and raised a concern about patient being neglected by his caregiver.
So, Dr. Lakmi, what injuries would you raise suspicious of elderly abuse in this patient?
Yeah, so elderly abuse is commonly under-recognized and under-reported due to multiple reasons. So there are 5 types of elderly abuse, categories of elderly abuse, that is physical abuse, sexual abuse, neglect, psychological abuse, and financial exploitation. So physical findings wise, the physical findings suggestive of elderly maltreatment or abuse are the injuries inconsistent with the mechanism reported, and also co-occurrence of new and old injuries, and then abnormal, atypical patterns of injuries. Like for instance, they can have features like injuries of attempted restraint, like having abrasions in the wrists and ankles, and skin tears and ligature marks in the ankles and wrist, and then abrasions in the axilla. And then abnormal, like bruising in abnormal locations like face, inner thighs, and inner arms, and also fractures of different healing stages. So there are various things that we can actually suspect elderly abuse.
Dr. Lakmi, if you suspect an elderly abuse case, how do you initially manage the patient in the ED?
Yeah. So the first thing is screening and recognition of elderly abuse. So there are validated screening tools that you can use, like Elder Abuse Suspicion Index. So you can use one of these tools and complement your findings. And then you have to do a thorough examination to find these physical, the injuries and the other forms of neglect. Then once there is confirmed elderly abuse, or if you strongly suspect elderly abuse, there are 3 things that you have to do. The first thing is ensuring patient safety. So if the patient does not require medical admission, you would still need to admit this patient as a social admission for the safety of the patient. And the second thing is treating the patient's acute medical conditions. And the third thing is reporting to relevant authorities. And I would say, we need to get a multidisciplinary approach if there is a complex case like this in the ED.
Thank you very much, Dr. Lakmi. So, Kanchan, what happened to this patient ultimately?
Yes, in the end, intra-abdominal bleeding was managed conservatively, and the neck of femur fracture was corrected with hemiarthroplasty, and the patient was mobilizing, and medical management optimization was done, and there were no features of elderly abuse, and the patient was discharged.
So one last question for the panel. Dr. Sithira, so what strategies would you suggest to prevent recurrent falls in elderly?
Thank you. The patient's fracture was corrected and now the patient is going home. But the problem is, will he fall again and will it result in another fracture? So as I said before, patients who fall are high likely to fall again. Okay, so recurrent falls is a problem. So we need to get a multidimensional approach to do a falls prevention. You might not be able to stop falls, but there are a lot of interventions that we can do to reduce the number of falls. So as I said, most of these falls, these are not accidental falls. There are no accidental falls. So these falls are mostly multifactorial, geriatric falls. So we have to do a comprehensive geriatric assessment and find all the possible risk factors, and then get a multidisciplinary involvement to correct these reversible factors. So that's the approach. And as I said, now sometimes we might not be able to stop falls. So it's very important to address osteoporosis in these patients. So bone protection is also very important. And when you say the multifactorial fall prevention, it's not only the intrinsic factors, but also the environmental factors and the behavioral factors. So that will be my approach.
Thank you, Dr. Sithira. So actually we have run out of the time, but the organizers allow us to have 1 or 2 questions from the audience.
We have.
Do you have any questions for our panel of experts?
We have a question by the virtual participants. That is one, is there a place for fat embolism in the list of complications? If so, management, please.
There's hardly any fat at that at that age. So fat embolism is low down in the list compared to a young person, and fat embolism is treated sort of conservatively. There's no active management that you can do. Basically, you manage the hypoxia, you manage the renal failure, you manage the skin conditions. That's how you manage if you get fat embolism.
The question number 2 is also from the virtual participants. Is there a place for diazepam for local anesthesia toxicity?
There's nothing to say it isn't, but we've got better ones in terms of benzodiazepines. So lorazepam is what is recommended, but if the patient is fitting, of course, there is a place for it. It's a bit of an old-fashioned drug, but you can still use it because you've got to control the conversion.
Any other question? Do you have a question there?
I have another question. With the Sri Lankan cultural and legal background, in an elderly patient who had a trauma, how can we handle these DNR decisions and end-of-life care decisions?
That's a good question. So actually, there are no legal provision to provide DNA CPR, but so there are professional recommendations that we can do DNA CPR. So if you look at the Sri Lanka Medical Association end-of-life care guidelines published in 2021, freely downloadable. So it's a chapter on DNA CPR. So we are professionally entitled to discuss about this DNA CPR decisions with the patients and the family, and with the agreement, you can it's safe to proceed with DNA CPR. So discussing about CPR, actually, so the success rate of CPR is quite low, and we actually think. So if you look at I just Googled and to see whether there are any local evidence. So I just found one research from one of the participants in the audience, Dr. Kaushila Dilakasiri. So the success rate of CPR is only 5%, including all younger patients and older patients. So when you get older, when you become multimorbid, the success rate of CPR goes down, right? And the other side is it's very traumatic to do CPR to elderly person with osteoporosis. It can result in a lot of undesirable effects like rib fractures, like having a traumatic death. So we have to always think whether it's futile to offer CPR and discuss all the pros and cons with the family. And if you really take time and discuss things, so I think we can get into agreement about whether to proceed with CPR or not. And it's quite important in this managing this kind of a person, especially before you go to the surgery, because these people are highly likely to get cardiac arrest perioperatively. So if you discuss it beforehand and document with the agreement of the family. So it's a medical decision, but it always needs to be discussed with the family. And if you have that already documented, then you should be safe.
Thank you, Dr. Sithira, for that comprehensive answer. So, sorry, unfortunately, we have to conclude the session here. Let's give a big thank for our expert panels. Right?
Thank you, our esteemed panel and moderators, for those valuable insights on managing elderly trauma. Now I would like to call upon Dr. Harendra Heva Pathirana, consultant emergency physician from District General Hospital, Matale, to deliver the tokens of appreciation for our panels of speakers. So I would like to, yes, Dr. Lakmi Hannadige, Consultant Emergency Physician, Dr. Sithira Senevirathne, Consultant Geriatrician from National Hospital Sri Lanka, Dr. Keerthi Abeyjeewa, Senior Consultant General Surgeon and Country Chair for ATLS, Dr. Vihara Dassanayake, Senior Lecturer in Anesthesiology and Consultant Anesthetist.
Thank you. It's time to get ready for an engaging and mind-opening session, post-stent crisis, navigating acute myocardial infarctions in emergency care. The battlefield of acute myocardial infarctions has been forever changed by percutaneous coronary intervention, a game changer in cardiology.
But challenges are always dynamic and often unforeseen. Stent thrombosis, in-stent restenosis, and ischemic recurrences remain formidable adversaries in emergency care. Managing these high-stakes scenarios requires precision, speed, and mastery of latest advancement.
To lead us through this fascinating and critical topic, we are thrilled to have true experts in the field. Let me welcome the keynote speakers for the day, Dr. Chandike Ponnamperuma, an esteemed distinguished senior consultant cardiologist, renowned for the expertise in interventional cardiology at National Hospital Sri Lanka. Can I invite you onto the stage, sir? Dr. Krishantha Jayasekara, a name that doesn't need introduction at all, a renowned, prestigious senior consultant physician at National Hospital Galle. I think some of you must have had the privilege to be taught under Sir because Sir is an exceptional teacher, and he's the president-elect for the 2025 Sri Lankan College of Internal Medicine. Dr. Nandana Jayathilake, Consultant Emergency Physician, National Hospital Kandiah, the past president of Sri Lankan College of Emergency Physicians. Dr. Kandiah Manitheepan, Consultant Emergency Physician, Teaching Hospital, Jaffna, member of Toxicology Special Interest Group, Royal College of Emergency Medicine, and council member of Sri Lankan College of Emergency Physicians.
Let me introduce our moderators for this symposium, Dr. Prabodhini Wickramaratne and Dr. Viduni Wickramasinghe, Senior Registrars in Emergency Medicine. Without further delay, let's dive into this insightful discussion.
Thank you, Metmal and Hasena. It's another exciting day in the emergency department. Viduni, trial just informed me that we have a new patient at Resuscitate 1.
No worries. We have an experienced panel of consultants today. Let's go see the patient. So our patient is 52-year-old Mr. W, a manual worker, presented with central crushing chest pain for 2 hours duration. It is associated with nausea and sweating, and the pain radiates to bilateral jaw. He has had an inferior MI and underwent primary PCI 2 weeks back. He was discharged on day 4 following an uncomplicated recovery, currently on dual antiplatelets. He has had diabetes for 15 years and oral hypoglycemic agents. He stopped smoking recently after the last MI. On examination, patient is talking, the airway is patent, lungs are clear, saturation is 97 on room air, pulse is regular, pulse rate is 105 beats per minute, capillary refilling time is 2 seconds. blood pressure 110 by 70 millimeter mercury, dual rhythm, no murmurs. The patient is alert with a CBS of 130 milligrams per deciliter. Pain score is 9 out of 10. He is sweating and afebrile. I would like to direct my first question to Dr. Nandana Jayathilake. Sir, what do you think of this patient in terms of differential diagnosis as well as assessment?
First of all, thank you very much for having me here. So this is the case, you got the patient with 52-year-old patient with long history. But if you come across this sort of patient in the emergency department, what we need to know is the summary of the summary. So if I look at this patient history, I would say this is the patient presenting with ischemic type chest pain, probably in cardiac origin, with stable vitals and background history of high cardiac risk factors. So that is the summary of the summary. So looking at this patient history, there are many things that come to my mind. The causes would be cardiac or non-cardiac. Of course, everybody would say, since this patient coming with ischemic type of chest pain, top of the list is could be an acute coronary syndrome, could be a myocardial infarction or non-STEMI, or it could be a unstable angina. And apart from that, the patient is having patients taking aspirin and clopid, and with recent MI, it could be a pericarditis, cardiac tamponade, though the hemodynamics are normal. And also, the patients I would consider about the aortic dissection as well. Apart from that, since the patient is on dual antiplatelet, other thing I would consider a non-cardiac in origin would be a peptic ulcer disease. And apart from that, what about the respiratory tract? So the patient coming with the chest pain, could it be a pneumothorax or hemothorax? So those are my main differential diagnoses. There are so many differential diagnoses, but as far as the emergency department is concerned, we need to have a most critical differential diagnosis where patient would die within few minutes if you don't attend.
Thank you, sir. That's an excellent explanation. Dr. Manitheepan, sir, in addition to the initial information provided, what further history and examination findings would you like to elicit in this patient to narrow down the differential diagnosis?
Thank you for this opportunity for the SLCEP for organizing this conference. So this is a common scenario we encounter day by day in our departments. So in all over Sri Lanka, this is a common scenario. So common things are common. So we all have to think of the common cause of cardiac, the chest pain is cardiac. So you have your questions, your history and the examination or your approach should target all the differential diagnosis. So you have to ask about the history and chest pain, whether it's the cardiac sounding chest pain. So you all know the cardiac sounding chest pain. So your questions should be directed towards the differential diagnosis, like is it due to ischemia or is it due to aortic dissections? So if you are a chest pain coming with ischemic chest pain, you have to ask about if this is constricting, because people have different explanation for their pain. So they are explaining in a different ways. So as a clinician, we have to direct our questions and aiming our questions specifically. And at the same time, you have to look at the differential diagnosis. So, and your history is, thorough history is important. Even the patients, you can ask the patient, but the patient is in pain, but you can ask the patient, or you can ask the ambulance crew or the paramedics, or you can ask the patients from the relatives or the bystanders or the next of kin who is available there. So you have to ask, the history is very, very important here. And at the same time, you have to ask, you have to thoroughly examine the patients. You have to look all your sense, and you have to look carefully and listen to the heart and use all the skills of examination and look for all the differential diagnoses.
Thank you, sir. Let's go back to our patient. Patient had no tearing type of chest pain radiant to back, no features suggestive of DVT, Wells score is less than 4, no history of fever, cough, or shortness of breath. Bilateral air entry is equal, trachea midline, no added sounds on auscultation, no radioradial or radiofemoral delay, No BP difference in both arms. No epigastric tenderness. Abdomen was soft. Dr. Jayathilake, sir, we have now got the ECG of this patient. What do you think about this ECG?
Again, the trouble comes to me. Yes, 2 LED ECG. Yeah, there is ST elevation in inferior leads, lead 1, 2, lead 2, 3, and AVF. And apart from that, I can't see. There's ST depression, reciprocal changes in AVL as well. So this sounds, this patient's having inferior infarction. But I'm not quite certain whether this ST elevation is the, the cardiologist would agree with me, is whether this is persisting with the previous one, since this patient, the PCI done about 3 weeks ago, or can I see, do you have a previous ECG with this one on discharge?
This is the ECG on last discharge.
Yeah, so that ECG shows only T inversion in inferior leads. So this probably, most probably, so this ECG shows ST elevation. So this could be acute ST elevation myocardial infarction. Either it could be a stent thrombosis or could be a new one. But since it's involving the same territory of inferior, I would say it could be a, most probably is stent thrombosis.
Thank you, sir, for the enlightening discussion. Let's explore ECGs in greater detail. Dr. Ponnamperuma, sir, can the stent thrombosis present with changes other than ST elevations in ECG?
Yeah, ST elevation in ECG is due to acute total occlusion of a coronary artery, which is basically no perfusion to that artery. So if this is a partial occlusion, there could be changes like any other non-STEMI. If this vessel has collateral supply, if it's a chronic lesion, maybe a 99% lesion which was there earlier, which developed collaterals to the same segment, got occluded after time, it can show other changes like T inversions or ST depressions without ST elevations. However, stent thrombosis itself is a vessel which was opened recently and now getting acutely occluded, and most of the time presents with the ST elevations. And one other thing here in this ECG, it is the most important feature in this ECG is the reciprocal change, the ST depression in AVL. None of the other causes of ST elevation will show reciprocal changes. And if you excuse me further, to point out one other possibility in a patient presenting after STEMI in 3 weeks is pericarditis. Pericarditis also can have ST elevations, and that ECG will not have reciprocal changes. Instead, it will have PR segment depressions in the same leads as ST elevation, and pericarditis also can be localized to the same segment as the previous infarct.
Thank you, sir. My next question is also on ECGs. How do we diagnose a new STEMI in a post-PCI patient with residual ST elevations using an ECG?
It is very helpful if you have the last patient's last ECG, the ECG on discharge, to compare with. If there's any increase in ST elevations, it will be very suggestive. However, again, the most important, two important things is, one is the presence of reciprocal changes. As I told you here, the most important is this AVL ST depression, which points to a reinfarction, and the dynamicity of the ST changes. That is, if you are in doubt, you should always repeat the ECG in 10 minutes. And if it's a reinfarct, the ST segment will change. It will be taller than the previous one. Those two will be the factors to be considered.
That was a highly constructive discussion, sir. Dr. Manitheepan, sir, apart from the 12-lead ECG, what other point of care investigations would you like to conduct in the emergency department?
As an emergency physician, we are fond of this point of care testing all the time. So I think any patient who is coming with a chest pain, first point of care test is ECG, we all discussed now. So that need to be done within 10 minutes of arrival. I think all over the countries agreeing or they adhere with that protocol is they are doing ECG within 10 minutes. Even the minor hospital, the base hospital and district hospital, they are doing. So that one thing we have to do. That everyone should emphasize that and do it as a first line point of care test for any patient who is coming with chest pain. So in addition to this, so if there is a changes in ECG, then we have to consider always the point of care test is the troponin. The troponin, there are special centers. In most of the centers, we have the point of care troponin, the high sensitive troponin, but not in other hospitals, but some centers, they have the point of care testing troponin. But as a clinicians and emergency physician, we are all used to this point of care ultrasound. So point of care cardiac ultrasound is, we are not a cardiologist to do the full ultrasound, but we can do and see, is there any regional wall motion abnormalities? Or based on the ECG. For example, if an inferior ischemic changes, we are looking at the inferior wall. And if there's an anterior septal changes, we are looking at the septal and anterior wall movements. And we can have an eyeball and we can have an idea about how the ejection fraction is. So, and at the same time, we can look for any other abnormalities like any pericardial effusions or any we can see whether there is any valve abnormalities or anything. Like we are not, as I said, we are not a cardiologist, but we can see the point of cardiac ultrasound. At the same time, we can look for the complications of this myocardial infarction. Looks like pleural effusions, or is there any changes like pulmonary edema? Like we are looking for B profiles in the complication of MI is a pulmonary edema, which shows B profiles in the lung ultrasounds. So we can look at that one. At the same time, we can look for the IVC, collapsibility of the IVC. So that also we can look at. So that's the other thing. So one thing is ECG, and second thing is a point of care troponin if there's any available. If not, we have to send the troponin for laboratory. That will be able in 1 or 2 hours. But another point of care test which you are doing is this point of care ultrasound. In addition to that, we have to do other tests which are point of care like random blood sugar. That is one of the point of care tests we are doing for all the critical ill patients. And at the same time, if there is any complications of myocardial infarction like cardiac failure, we can do an ABG to decide about the type 2 respiratory failure or pulmonary edema.
Thank you, sir. That was clearly explained. We also did a point of care scan in this patient, which showed regional wall motion abnormality involving the inferior myocardium. Eyeball ejection fraction was around 40%. Aortic root was not dilated. No aortic flaps were seen. No RA-RV dilatation. No pericardial or pleural effusions. Lungs A profile. High sensitivity troponin was sent to the lab.
We think it would be valuable to explore the topic of biomarkers in greater depth. Troponin levels can remain elevated for 10 to 14 days following a MI and for 7 to 10 days after a PCI. Dr. Manitheepan, sir, in a patient who has recently undergone stent placement and presents with ischemic chest pain along with new STOT changes, what role does troponin play in guiding management?
So when you consider the patient who is coming with a chest pain, if the ECG is suggestive, so ECG suggestive ST elevation MI, when we are comparing with the previous ECG, we are not bothering about the troponins. If there is high sensitive troponin is available, we can do that. Otherwise, we will straight away call the cardiologist and go for a primary PCA, or we decide about thrombolysis. But if the ECG is equivocal, or you can't make any decision based on the ECG, there is a place for troponin where we can do the troponin. But in a patient who had a STEMI, as she said, so the troponin values are elevated for 24 hours, high peak in the 24 hours, and it comes down and it will be very low in around 10 to 14 days. And so that's a pattern of troponin level rising and coming down. So when you are doing a troponin, single troponin test, won't give a clear answer if it is in the acute phase. So if you do a serial troponin, it will give a clear idea about how the patient is and where the patient is. So if the patient is based on the previous MI, if the patient is having a high troponin, it will come down in the coming down phase. So it will come down in the repeat troponin. So if not, if it is in a rising phase, then we have to think of there's a new ischemia or new onset. But we are not depends on this troponin all the time, because if the clinical signs are suggestive and the ECG is suggestive and the point of care testing is suggestive, so it's a collective decision. So if all this is suggestive, then we are straight away calling the cardiologist for the help.
That was truly enlightening, sir. Troponin and CKMB are currently the most widely used cardiac biomarkers. Dr. Jayasekara, sir, are there any promising new biomarkers emerging for the management of acute coronary syndrome?
Yeah, thank you very much. So I think still the gold standard biomarker is troponin. So we all do go for, the emergencies are very fond of 1 hour rule out criteria, 3 hour rule out criteria, depending on troponins. If you look at this bar charts, you can see what we have done over the last few generations was increase the sensitivity of troponins. So what it finally ended up with, the specificity has dropped a little. You can see the 5th generation troponins, the sensitivity is very high, but the specificity had dropped. So you might see some non-cardiac diseases also leading to positivity. So this, of course, has led to the inventors to look for new biomarkers, one for diagnosis, other one for prognostication. So there are various, cytosolic biomarkers, and then so there are, plaque instability, inflammation. So there are high sensitive CRP. So one of those golden things would be this heart muscle fatty acid binding protein, which of course is a new biomarker which is coming up. And I think if you look at the next slide, you can see how now on your right, on the red, what is given the HFAP. So it is highly sensitive and specific as well, closer to myoglobin. And then, after 24 hours, the values come down to baseline levels. So this is a very good biomarker, high sensitivity, high specificity as well. It is cleared from your circulation within 24 hours. So I'm pretty sure in the future, this will come in line with troponins as a combination, adds more value into ruling out ACS in the emergency department. So this is the trend forward. So definitely this will come up in the future guidelines. Thank you.
Thank you, sir. That's a fascinating discussion. Let's go back to our patient. The patient received antiplatelet loading doses, aspirin 300 mg, clopidogrel 300 mg, and atorvastatin 40 mg. IV morphine 5 mg was given for ongoing pain, and pain subsided to 6 out of 10. Transfer to cath lab was arranged. Dr. Jayasekara, sir, in acute coronary syndrome, we all say that stat doses are given, which include aspirin, clopidogrel, and atorvastatin. It is well established that all patients suspected of acute coronary syndrome should receive a loading dose of soluble aspirin. However, the recommendations for P2Y12 inhibitors are less clear. Can we discuss a little bit about P2Y12 inhibitor loading doses in acute coronary syndrome?
Of course. I think P2Y12 inhibitors, there are pros and cons. Pros would be because it will prevent thrombosis, and it will, the stent longevity will be increased. Whereas if you use it for, inadvertently if you use, it can cause bleeding. So what you need to do, you need to revisit latest guidelines, the ESC 2023 guidelines, and then what you could see is that P2Y2 inhibitors you can see for all acute coronary syndromes. If it's a STEMI, so you need to go for prasugrel or ticagrelor over clopidogrel unless the patient is old or unless those two are not available. And so the choice would differ depending on the patient's, whether it's a STEMI or non-STEMI. And also if it's a non-ST elevation MI, it's a class 3. You should not use P2Y12 inhibitors in a non-STEMI as a pre-treatment loading dose. So you can see it's on the red bar. It's a class 3 evidence for use of routine antiplatelet regime for PCIs. So the message is, if it is a patient is going for a STEMI, you need to go for either Pachugal or Ticagrelor. If it's a non-STEMI, you should not, if the patient is immediately going for PCI, you should not load them with P2Y12 inhibitors. What do you think, Chandike? Is there anything that you want to add?
Yeah, for STEMIs, definitely you need loading of both antiplatelets. For non-STEMIs, aspirin should be loaded, and the P2Y12 inhibitor can be loaded after the angiogram before the PCI on table. So that is the reason recommended. That is because if the patient has to undergo bypass surgery urgently, loading P2Y12 inhibitors will increase bleeding risk and will delay the surgery. That's the reason.
Thank you so much, sir. Dr. Jayasekara, I have another question for you regarding statin. In acute coronary syndrome, high doses of statins are recommended and prescribed. Do you believe this approach is advisable? What does the current evidence state regarding that?
Yeah, I think the statin loading had been there for nearly more than a couple of decades. So 80 milligrams to 40 milligrams of atorvastatin, 20 to 40 of rosuvastatin. Other than the plaque stabilization, there are many added advantage of statins. So now there are new thoughts coming in whether you should load them in addition to ezetimibe. There are recent trials coming up, and this was a 2023 AACC guide recommendation, and I'm pretty sure this will again now, in addition to statin loading, ezetimibe loading will also, in addition to statin, will come up into the picture very soon and might come up in the guidelines in the future.
Thank you very much for sharing such a well-rounded perspective, sir. Meanwhile, Mr. W underwent an emergent PCI and was found to have a thrombus occluding previous stent. Let's now shift our focus to PCI. Dr. Ponnamperuma, sir, with your extensive experience as a senior cardiologist performing PCI regularly, could you share the common immediate and late complications you have come across during PCI?
Well, immediate complications are, the commonest ones are, particularly in the acute coronary in syndromes, is one is acute stent thrombosis, where you can see stent thrombosis on table or within the first 24 hours. Then there's a phenomenon called no reflow phenomenon. That is, the vessel is open, but the flow is not there. Multiple reasons are thought to cause this, and the commonest being distal embolization of the capillary bed with thrombus and debris of the cholesterol plaque obstructing the capillary bed. And in addition, vascular dissections and perforations causing pericardial effusions are the dreaded complications or immediate complications which we can see on table. So we have to take every possible step to prevent these because they have a very high mortality.
When I read the literature, sir, there was two types of stent failure there. They have mentioned stent thrombosis and in-stent restenosis. Are those two the same or different?
Those are two types of stent occlusion. Stent thrombosis is basically a clot occurring on a patent stent and causing occlusion. In-stent restenosis is a bit different. When we place a stent inside a coronary artery and oppose it to the vessel wall, with time the inner lining, the intima, grows over the stent and covers the stent. That is our expectation. When that occurs, only the risk of stent thrombosis will reduce. That is why we give dual antiplatelets for 1 year, and after that we continue single antiplatelets. And because in almost all cases, the covering of the cell stent, the metal layer by the intima is complete by about 1 year. However, sometimes as a reaction to the foreign body, the intimal cell layer can hypertrophy and narrow the stent lumen. That is called, and the smooth muscle grows in, and the vessel wall inside the stent gets thickened and narrows the stent lumen. That is called in-stent restenosis. So those two are pathologically different. However, in-stent restenosis patients can get late stent thrombosis on top of that. Therefore, both can coexist as well.
So the presentation wise, will there be a difference?
Yes. Acute stent thrombosis presents as any other myocardial infarction. In-stent restenosis is more likely to present as angina, exertional angina.
I'd like to touch briefly on stent thrombosis. Some of you may feel my next questions are outside the typical scope for an emergency physician. Still, given the increasing number of post-PCI patients we encounter, I believe it's important to discuss. Dr. Ponnamperuma, sir, what types of stents are currently available and which ones are more prone to restenose and thrombose?
Broadly speaking, two types of stents are there: bare metal stents and drug-eluting stents. Bare metal stents are now very rarely used, actually almost non-existent. The only indication for a bare metal stent is a PCI during pregnancy. Otherwise, almost all stents which we use are drug-eluting stents. The bare metal stents, the advantage is there is no, the drug-eluting stents, the drug it has is antimitotics, right? Like paclitaxel, sirolimus. They prevent intimal hyperplasia or overgrowth of intima over the stent, causing restenosis. The negative side of having the drug on it is it delays endothelialization of the stent. Therefore, there slightly increases the risk of stent thrombosis. On the other hand, bare metal stents, the in-stent restenosis rate is high because there is no drug to combat intimal hyperplasia. Therefore, the lumen can narrow with intimal hyperplasia. However, stent thrombosis is rare because it rapidly gets covered by the endothelium. Those are the two differences.
What are the interventional options that are recommended for stent thrombosis during PCI, sir? And out of which ones are available in Sri Lanka for us?
Well, when a stent thrombosis occurs, the urgent need is to open the vessel. Somehow you have to open the vessel and perfuse the coronary. So you put a wire, suck out the thrombus if possible with a thrombus aspiration catheter, balloon it, give more antiplatelets and antiplatelets mainly. You can give intracoronary abciximab and try to keep the vessel patent. Having established the flow, then, so those things are available for, we have thrombus aspiration catheters, we have abciximab, right? We can balloon the vessel and open the pathway and have the myocardium perfused. Having done that, then we have to find out why this stent has got thrombosed. It could be due to antiplatelet issues, where the patient has either not taken antiplatelets or antiplatelet resistance, or it could be due to a local issue like malapposed stent, a stent fracture, or a dissection at the either end of the stent. All can increase the risk of stent thrombosis. To find out the cause, it is important to perform a intravascular imaging. Sometimes the cause is obvious when on fluoroscopy. If not, anyway, it's what is recommended is to do a intravascular imaging like intravascular ultrasound or OCT. OCT is optical coherence tomography, where you put a catheter in, which is imaging tool, and you see from inside we can see the stent and the vessel wall clearly. And those are not freely available. OCT we don't have. IVUS we have. It's extremely expensive and not widely available in all the cath labs. So we perform IVUS very rarely. Other tools we have.
Thank you for sharing your insights, sir. I'm sure many of us have gained valuable new knowledge.
Now let us imagine this patient present to a non-PCI hospital. There's a dilemma whether to go ahead with thrombolysis or not. Dr. Jayathilake, do you think there is a place for thrombolysis? If so, what are the pharmacological agents that can be used?
Okay, thank you again. So now this patient coming to the emergency department, fortunately I have my cardiologist at National Hospital Kandiah. I straight away discuss with them. But of course, there are centers where you don't have PCI. So what to do? First of all, before talk about the thrombolysis, can I add a little bit more? Now when you come across the patient with ST elevation myocardial infarction, most of us and most of nurses and your junior doctors are very fond of inserting the cannula. Why? If I ask somebody, don't know, so they insert the cannula. But even before inserting the cannula, make sure that you connect the patient to the adhesive pad, defibrillator pads. That is because I have come across so many patients, but I don't have figures to say, they develop ventricular arrhythmias, which has to be defibrillated and which is life-saving. To insert the cannula and start in thrombolysis, yes, it takes time. So when you come across a patient with acute myocardial infarction, there are 4 things that you have to do. First, the diagnosis. Second, to see the complications. Third, definitive treatment. And fourth is the destination, where your disposition. So yes, so we have diagnosed. Now next thing is to see the complications. If there is no other complications, yes, I would look for the thrombolysis. Basically, we have tenecteplase. And also, some centers, they don't have tenecteplase. So we have STK, streptokinase as well. So I preferably use tenecteplase with the preloading of IV enoxaparin, IV, and after the thrombolysis, we have to use the subcut enoxaparin 1 milligram per kg.
Thank you, sir. Dr. Ponnamperuma, sir, would you like to add anything to that discussion regarding thrombolysis?
In the absence of PCI capable, in a non-PCI capable hospital, I think it should be managed as any other ST elevation myocardial infarction.
Okay, thank you, sir. Sir, in that case, if I go ahead with thrombolysis, do we need to consider the time since stent insertion before thrombolysis, whether it's an early one or a late one?
No, my only concern is which artery, the access through which the previous stent was. If it's a radial access, then it's very easy. Even if bleeding occurs, it's a matter of applying pressure. If it's a femoral access, still I will go ahead with thrombolysis, but I will closely observe the femoral region because there could be hemorrhage, hematoma causing problems with the femoral access. Otherwise, it doesn't matter.
Thank you, Dr. Jayathilake and Dr. Ponnamperuma. That was a real eye-opener. Anticoagulation is essential in acute coronary syndrome. Dr. Jayasekara. Sir, is the use of parenteral anticoagulants any different in presumed stent thrombosis than in routine acute coronary syndrome management?
It's not so. Now, if you look at the guidelines, I think Nandana has also mentioned something on enoxaparin loading as well. And if you are going for a thrombolysis, of course, you need to go with the enoxaparin loading intravenous followed by subcutaneous till you get the angiogram done And also, if you are planning for a PCI primary, then of course the cardiologist would be happy to use intravenous heparin, dose suggested heparin. So depending on the procedure plan, you can either give intravenous, if you are going for now this patient, if it's a PCI able center, of course it would be a heparin. If otherwise, it would be intravenous enoxaparin followed by tenecteplase.
Thank you very much, sir. Dr. Ponnamperuma, sir, let's imagine that the same Mr. W also had chronic atrial fibrillation and was on clopidogrel and NOVAC. He is being managed for a suspected stent thrombosis now. In that case, how should we modify the antiplatelet loading doses this time?
Well, there will be not much of a change for the antiplatelet loading, but however you should remember now we are dealing with, the problem is more complicated. You are dealing with high bleeding risk versus high thrombosis risk. So you have to make your judgment as what is going to be more dangerous to this patient. So most of the time it is the thrombosis, and so if it's a ST elevation myocardial infarction where it involves a significant myocardial mass, I think we should manage with dual antiplatelets and then plan for thrombolysis. However, the best option in this instance is again trying primary PCI.
So if primary PCI is unavailable, is it safe to thrombolyze? In that case, can we use full dose of thrombolytics or should we use a dose modification here?
Well, there's no guideline to adhere to. So it's again judgment whether bleeding is going to be more dangerous or thrombosis. But the only dose reduction is recommended only for age in thrombolysis. So if we are thrombolizing, we have to thrombolyze the full dose.
So if we are thrombolizing, can we give the IV enoxaparin dose as well before the thrombolysis?
I would not recommend giving the IV enoxaparin. Already the patient is anticoagulated. Why we give enoxaparin is specifically when you use clot-specific thrombolytics like tenecteplase, it increases the risk of re-occlusion if you don't anticoagulate. This patient is already anticoagulated and therefore we should not give the IV enoxaparin dose.
Thank you very much, sir. Prabodhini, what happened to our patient?
Viduni, he had a thrombus aspiration and a second stent insertion just proximal to the previous one. He's stable and safe at the moment. We have done a good job. Great. Prevention is always better than cure. Dr. Jayasekara, sir, what are the risk factors for stent thrombosis and how can it be prevented?
Yeah, I think there are many risk factors. There are maybe patient-related risk factors that I will be interested in, but there are many things that a cardiologist, procedural and lesional related issues as well. So now for patient-related, there are many things. I think commonest in this country is very poor compliance with the dual antiplatelet, which I think you in the emergency department might be seeing many patients who have defaulted dual antiplatelet therapy. Of course, there are other things that we might not see as important, something like diabetes control, something like, control of hypertension, dyslipidemia, so other things, other medical conditions as well. And also something, some malignancies and some other medical conditions, thrombophilic conditions, right? So there are, there are modifiable things, non-modifiable things. There are subtle things that we might not consider as important, which might be very important for the longevity of stents. But overall, what I need to say is a very poor compliance. Either they are not well educated or they are not ignorant. And we have a role in educating these people, the importance of it and the consequences of stent thrombosis, which we have discussed so far in this symposium.
Thank you, sir. I wish we could continue, but due to time constraints, we'll need to wrap up. But before we finish, I can take a moment for any questions from audience. Questions?
In the absence of questions?
Yeah, I have one question from the audience of virtual participants. So if there's no indication if there's no facilities to go ahead with PCI for non-STEMI, patient with a non-STEMI, do we still give dual antiplatelets, maybe P2Y12 inhibitors for loading of this patient?
Yes, of course. If we don't have a plan of PCI, we should definitely give dual antiplatelets. If you have a definite plan, then you should withhold it. And as Dr. Ponnamperuma very clearly said, after the cath, you can load it on the table, or if the patient is not going for this thing. But if you're not planning, you should always give dual antiplatelets for a non-STEMI that we routinely do.
Thank you, sir.
In the absence of further questions from the audience, we would now conclude our symposium. We would like to thank all our panelists for such a comprehensive and thought-provoking discussion. We truly appreciate your time and insights. Thank you.
Thank you very much. Now I would like to invite Dr. Isuru Gayan, Consultant Emergency Physician from District General Hospital, Horana, to hand over the tokens of appreciation to the speakers. Dr. Chandike Ponnamperuma, Dr. Krishantha Jayasekara, Dr. Nandana Jayathilake, Dr. Kandiah Manitheepan, Now we are moving ahead to our next groundbreaking session, Beyond the Scalpel, Saving Lives Through Embolization. In the ever-evolving field of modern medicine, interventional radiology stands as a beacon of innovation. Embolization has emerged as a powerful technique, revolutionizing the management of life-threatening conditions, from controlling hemorrhage to targeting tumors with precision, all without the need for traditional surgery. Guiding us through this thrilling frontier is none other than Dr. Chinthaka Appuhamy, a visionary in diagnostic and interventional radiology and a true expert in the field, currently working as a consultant radiologist and senior lecturer, Department of Surgery, Faculty of Medicine, University of Kelaniya. Today's evening, Sir will take us on a journey beyond the scalpel, showcasing how embolization is not just a procedure, but a life-saving innovation. It is my privilege to invite Dr. Chinthaka Appuhamy to take the stage and enlighten us with his insights.
Thank you for the invitation, and it's a great privilege and honor to be here. And without taking much time, I will briefly go through my presentation, illustrating some of the case scenarios that we have encountered. Interventional radiology is a specialized branch of radiology that uses minimally invasive image-guided techniques to diagnose and treat a variety of medical conditions. IR procedures allow for targeted treatment with reduced risk, shorter recovery times, and fewer complications. So it will play a pivotal role in both emergency and elective medical care. So when it comes to emergency medicine or hemorrhage control, there are several aspects that we encounter these cases, such as trauma, postpartum hemorrhage, management of vascular emergencies such as acute hemoptysis and GI bleeding, then treating organ-specific complications such as renal trauma, liver lacerations, and splenic lacerations. And finally, I will touch upon a few images of prostate artery embolization as well. This patient presented to us with profuse nasal bleeding and subsequently underwent MRI imaging. With contrast, this post-contrast sagittal T1 weighted images shows a large mass in the nasopharynx, and it was decided to embolize before the surgery. So this was the selective angiograms of external carotid artery, the large vascular blush in relation to the nasopharynx supplied by the internal maxillary. And the first image shows the large vascular blush avidly enhancing, and subsequently it was embolized, and 3 days after that patient underwent the definitive surgery. A similar patient, again, juvenile angiofibroma, CT and post-contrast T1 weighted sagittal sequences showcasing a large mass in relation to the nasopharynx. And again, the oblique views of a superselective cannulation of the internal maxillary and the internal maxillary demonstrating enlarged blood vessels with large tumor blush, and it was embolized. So as an emergency procedure, we can embolize, and again, as a pre-surgical devascularization, so we can do it electively in these patients. Nasopharyngeal malignancies, squamous cell carcinomas, devastating conditions. This PET avid uptaking large mass in the right side of the neck, destroying almost all the neck spaces. So this lesion has eroded into the right carotid vessels. The angiogram demonstrates extravasation of contrast from the common carotid artery, and this was on table stented with a covered carotid stent, and the extravasation was excluded. So that was a life-saving procedure for that patient in that time. So it was called, it is named as carotid blowout syndrome, as you all know, and it's a very devastating, life-threatening condition. Hemoptysis is very common in Sri Lanka because of tuberculosis and other lung fibrotic conditions. Bronchiectasis, patients present with profuse hemoptysis at times. So what we can do is we can attempt bronchial artery embolization. So going into the thoracic aorta, doing the thoracic aortogram, and then superselective cannulation of the bronchial arteries. Commonly the third intercostal bronchial trunk in the right side, like you see here, there's a vascular blush. And not only the bronchial arteries, when we are tackling with hemoptysis, most of the time due to the pleural thickening and invasion, there is non-bronchial systemic blood supply as well. So when we are looking for the bleeder, not only the bronchial arteries, but again internal mammary and the posterior intercostal arteries also should be checked to visualize any pathological blood supply and block the blood vessels. So this is post-embolization. There is complete block of the right bronchial artery in that patient. Embolization in trauma. The visceral organ damage, again present with grade mortality. This patient presented with grade 3 liver laceration. The coroner reconstructed images of the CT shows a pseudoaneurysm and a large hematoma in relation to the liver. The selective cannulation of the celiac axis and superselective angiogram of the right hepatic artery shows this pseudoaneurysm. And it was coiled and the hematoma was excluded. Similarly, we can negotiate into the splenic artery for embolizations. So same technique, celiac axis going into the splenic artery, then dedicated coils and embolic materials are there where we can embolize the splenic bed, or we can take the splenic bed, or we can cut the blood supply from the main artery. Embolization in GI bleeding is a common presentation. Several etiologies are there, commonly the diverticulitis, colitis, tumors, and without any cause patients present with profuse GI bleeding. And this patient presented with active bleeding, PR bleeding, and this is superselective angiogram of the ileocholic artery demonstrating the cecum and the ascending colon. And this is the extravasation of contrast, as you can see here. So if we can go into the feeding artery, we can coil the blood vessel. So we have to be very careful not to embolize the normal tissues, because the patient will present with acute abdomen in few days' time if we do the necrosis to the surrounding the gut. So this is the embolization in GI bleeding. This is one such example. Another patient, a father of one of our doctors, presented for the third time due to acute diverticulitis of the sigmoid colon. As you can see here, this is the contrast going into the lumen. So that's contrast. So that's significant amount of active bleeding on table. So these were the previous coils, and again the bleeder was coiled and for the third time, and it was successful again. In certain instances where the postpartum hemorrhage we can tackle with embolization. So the technique here is we do the lower abdominal aortogram and find out both internal iliac arteries, and then selectively cannulate the side affected side, and in this patient the left internal iliac artery giving a pseudoaneurysmal dilatation here and active contrast extravasation. So two techniques are there. Either we can come from the left arm from the brachial puncture, or else we can routinely goes in from the common femoral artery. So if it goes from the common femoral artery, we have to negotiate this acute angle and going into the ipsilateral internal iliac artery, and secondly goes into the contralateral side and cannulate the other side internal iliac artery. So selective cannulation and embolization is important. Prostate artery embolization, as you may be aware, some of the patients, they are not suitable for surgery. Sometimes they present with a large amount of blood or hematuria. So the patients are not suitable for GA, and the selective prostate artery embolization can be carried out. This is one such example. a massive prostate with a significant amount of bleeding. And this angiogram shows the microcatheter is within the left prostatic artery. The large area is the gland. So again, spot images of the prostatic artery from the left side. So these can be coiled, and we can inject other embolic material. Lastly, you may be aware about catamenial hemoptysis. This patient presented with cyclical hemoptysis, and the last episode was a profuse one. During menstruations, she gets this hemoptysis, and the thoracic CT showed a focal area in the right lower thorax, and subsequently she underwent bronchial artery angiogram and showed this abnormal blush, and it was we managed to embolize this area, and it was subsequently healed. So the advantage of embolization is it is minimally invasive, and it has a fast recovery time, a reduced risk compared to the traditional open surgery. The potential there are potential complications, catheter-related complications, and vascular injuries. So these are some of the complications, and we need skilled interventional radiologists for these dedicated procedures. So these are some of the challenges and limitations. So in summary, embolization is a critical tool in emergency medicine, offering rapid, effective intervention for life-threatening conditions caused by excessive bleeding. By applying image-guided technology and specialized embolic materials, interventional radiologists can provide targeted treatment that improves patient outcomes, reduces the need for invasive surgery, and saves lives in urgent medical situations. With that note, I would like to conclude my presentation. Thank you. Any questions?
Thank you, sir. Could you remain on the stage, sir, to receive a token of appreciation? For that, I would like to invite Dr. Viraj Rajpaksha, Consultant Emergency Physician, General Hospital, Panadura, to hand over the token. Thank you very much, sir. Ladies and gentlemen, it is the final session of the day. Our next session is sure to be both engaging and impactful, a true highlight in emergency medicine topic, fast and focused point of care testing. In the world of emergency medicine, where time is often most critical factor, point of care testing is nothing short of a game changer that transforms emergency care where speed and precision are paramount. Leading us through this high-impact topic is none other than Dr. Thanuja Darshani, Consultant Emergency Physician, Sri Jayawardenepura General Hospital. Madam is a founding member of Sri Lankan College of Emergency Physicians and holds international accreditation in point-of-care ultrasound from Pocused Academy, United States of America. Madam, over to you for the final plenary.
Okay. Good evening, everyone. We have come to the end of our session. So I have, I think, 20 minutes. So we will do, I will try to do this lecture as fast as possible. You need to be focused, okay? So this is all about point of care testing. If you listen to carefully to all the our expertise from the morning so far, they were talking about some kind of testing which help them to initial assessment and management of the patients. So basically, as within the 20 minutes, I can go through much about the point of care testing, but I will tell you about how it is important as emergency physician and in a low resource setup to manage your patient, okay? So I will briefly go through what is the point of care testing and what are the things we can do it and how it is completely changing your management and some limitation of doing the point of care testing. So if you come to the definition, what is point of care testing? Point of care test means the tests which are done at the place where you treat the patient. Rather than sending a sample or patient to out of your department, we do all the tests around the patient. So simply that is point of care testing. There are different names and definition, but just keep it in mind. So I would like to go through a case, then it will be more elaborating. So I got a 70-year-old lady who presented with right-sided chest pain, shortness of breath, and as usual, they are having a multiple medical problem. She's a known patient with COPD, on inhalers regularly, and diabetic and hypertensive. These are the examination findings. So she's tachypneic and saturation was low, and you can hear both bronchi and crepitation. And she's tachycardic, but there are no evidence of shock. And her GCS is 14, and we did a bedside, again, point of care testing, random blood sugar level, it is quite high. So depending on this examination and history, what are your DDs or the diagnosis? So I would say she's known patient with COPD and now presenting with right-sided chest pain and worsening of shortness of breath. And on top of that, you can hear bronch and crepitation and saturation also low, and she's dyspneic. So depending on this history and the examination, my most likely diagnosis is exacerbation of COPD. What about you? And the other thing is, because she's an elderly lady presenting with chest pain, and she is having sweating, and there is significant risk factors for ischemic heart disease, diabetic and hypertension. Therefore, I also keep in mind this could be a possibility of ischemic cardiac event leading to heart failure. And also I can see her random blood sugar level also high, so there may be a hyperglycemia. I did a bedside ECG. Again, it's a point of care testing, but it didn't help me much. There was some T-wave flattening in the lateral leads, so I couldn't able to make any specific diagnosis with the ECG. So at the moment, my most likely cause is the exacerbation of COPD. There could be a ischemic APO with hyperglycemia. But luckily, I have point of care testing in my department. I hope most of you are having. So I did a point of care ultrasound because I love to do it. And while during taking the history and examination, I just keep the probe. I can see a lot of B lines. And then I just did a point of care echo. I can see the contractility of the heart is also reduced. And IVC is full. Now, this is not a COPD exacerbation. This is cardiogenic pulmonary edema. Now, I'm getting my troponin. It is 5.2. It is high. So now this cardiogenic edema has a ischemic component. Already I have some idea, her blood sugar level is a little bit high, therefore I want to know whether there is a acidosis or not. So I did a blood gas. So there are so many values come with the blood gas, but I just focused because these values with this case, there is a acidosis. And if you are thinking of respiratory acidosis with the exacerbation of COPD, I would like to see more carbon dioxide retention, but this is washed out. So again, it is unlikely. And now this patient is having metabolic acidosis, but lactate level is normal. Can you see? Yep. And also, with, even though she is having a multiple comorbidities, her creatinine is still quite good. So with now your patient having high random blood sugar level, in the VPG it shows 402, she is having metabolic acidosis, still lactate is normal. What do you want to exclude? DKA, right? Yes. We have point of care testing again, DKA, capillary ketone bodies level, it came as positive. So what is your now diagnosis? It is ischemic heart failure with DKA. So if I didn't had the point of care testing in my department, I would give some nebulization with Salipra, and then I will consider some steroid, and on top of that, I will give some antibiotic. Meantime, I can hear some crepitation and having a second thought of heart failure, therefore, I will cover it up with some furosemide, isn't it? But now, if I start that treatment to this patient, that condition completely deteriorating because that patient is having ischemic heart disease and giving steroid, some beta blockers like salbutamol, further beta agonist, further worsening her condition. So on but without doing that, I start her on CPAP and gave her loading doses with enoxaparin and start furosemide and control her blood pressure. So for the hyperglycemia now become DKA. This is not a hyperglycemia anymore. This is DKA. For that, we can't go adhere to the proper guideline because this is a patient with now fluid overload. You can't directly use the protocol. So we limited the fluid and start the insulin infusion rather than giving a bolus. So I hope this case give you some good impression how the management is changing with the point of care testing. In a summary again, why do we need to do point of care testing? This is a summary. So when a patient comes to your hospital, at triage, they will categorize. So one of the doctors will assess the patient, take a quick history and examination. We don't have much time in emergency department. And you make your diagnosis or differential, depending on the patient. Most of the time, you come to the differentials rather than a direct, straightforward diagnosis. So in that case, you have to start treatment, and meantime, we have to wait for the blood results. If you send the bloods to the routine laboratories, it will take time. What do you think? It's minutes or hours? It may be days, right? Because we have to collect the sample, and we can't send each sample every time. We have to wait. Few samples are collected in the emergency department, then it has to be labeled, then transport to the laboratories. They again waited to run set of sample, waiting for more tests. So while meantime, you get the report in couple of hours, maybe days later, and you're shocked how my patient survived. Potassium is 7. So that is how, if you are having the investigation then and there, you can make the decision, and therefore you can discharge or make the decision to discharge or admit this patient. So it is fast, not because I am doing the lecture fast, because you are taking the blood, whole blood. It doesn't need any centrifuge, serum or plasma. So whole blood, even with a small volume, you can run the test. And this technique is very simple. You just need to put the blood or drop of blood into a strip or some tube. And it is inside your department, and there is no need of technician. Usually, previously, before I getting a blood gas analyzer to my department, I have to send the blood gas to the ICU. Then the technician is not available after 4 o'clock. So I'm managing the hyperkalemia by doing the ECGs and thinking, probably there is no dented T waves like that, right? So now it is in your department, you don't need any technician, and results are coming within minutes. But don't do the point of care testing before doing your proper clinical assessment. Always, point of care test should be come after after your proper clinical assessment. For example, I would say, if a patient coming with a chest pain and the nurse has taken the blood and run a troponin test, it is come as positive, and now she is run to you and telling doctor the troponin is positive. You are looking at the troponin level, you're thinking, and the same time you got the ECG as well. It shows either STEMI features or some kind of non-STEMI features. So you're managing as a patient with either STEMI or non-STEMI by giving dual platelet, either you decide thrombolysis or giving enoxaparin. But once you start the treatment, suddenly pain getting worsened and your patient got arrested. After that, you go back to the patient and the family, and patient is anyway now not in a situation to talk. So when you go back to the family and ask the history, he is giving a now typical history of radiating pain to the back and severe crushing type of pain. And nurse somewhere recorded there is a difference in radio delay. So you have thrombolized a patient with aortic dissection. So that is why our clinical sense come always before the point of care testing. But we already discussed a case, and there are many incidents. Even you have a good examination and take a proper history, still we can't make a proper diagnosis without point of care test. So your accuracy of the treatment and the diagnosis will be more and correct, more accurate when you are using the point of care testing. For example, if a patient can do a troponin at triage, it is very easy to decide whether this is a ischemic one or not. And because this is helping you for a rapid decision making, it will make you, when you are having initially differential diagnosis, now you have a proper diagnosis. Therefore, rather than giving a cocktail of treatment, you can give you a proper target treatment. Therefore, your patient's outcome finally improve, therefore the reduced mobility and the morbidity. And ultimately, we are happy and the patient also happy. We can increase the turnover time in the emergency department and prevent the clogging of the patient. Evidence for your actions, therefore, the liability is less. And ultimately, we are giving less burden to the central lab as well. Come back to the criteria for point of care testing. WHO has recommended some assured criteria. These for ideal point of care test should have these features. It should be affordable, sensitive, specific, and user-friendly, and very rapid, and equipment-free, and it should be deliverable to your patient. I will go back to the history. So before any of these technologies invented, initially there were document in 1550 BCs, in the papyrus document, there were Egyptian physicians using ants as a testing to check whether glucose in the patient's urine or not, in diabetic patient. But nowadays, the technology is advanced beyond the limits. So they have inventing day by day the new technology, like lab-on-chip technology with microfluid chips and biosensors, and miniaturization of the devices. Devices become smaller and smaller with advanced technique, with microprocessors and integrated ICs, and with the advanced material like strong material with lesser weight and the compact sensors and nanotechnology. On top of that, now artificial intelligence has integrated to most of the machines, and also the connectivity. Most of the now, if you're doing a blood gas and if you can't get into the system, so there is a gap between the patient data and your management. Some hospitals have all the system are in a electronic system, but still most government hospitals have a paper document. But once you move into the next level, you need the connectivity. So most of the current now point of care testing is moving with these advanced features. I would like to give you some couple of examples. So this is my loud machine, ultrasound machine. This is one of the previous old machine. So in emergency department, we don't have enough space to, even though I have this big machine, I don't have enough space to move this machine. But with the advancement of the technology, now it is come very handy, handheld pocket ultrasound. So while you are assessing the patient, like your stethoscope, you can now directly see what is inside your body. Likewise, the blood gas analyzer. So previous blood gas analyzer only gives some pH and the blood gas value and some electrolytes. But nowadays, it's far beyond. And you can have an idea about hematocrit and the electrolytes, not only the sodium and potassium. It will give you ionized calcium and the magnesium level. It is very helpful in patients, especially presented with arrhythmias or recurrent seizures, to know the calcium level and magnesium level. And also, we can get down the glucose level and the lactate, which is very important in patient with sepsis and the shock. And also co-oximeter values and the creatinine, especially if you want to talk to a nephrologist for a dialysis, or if the patient need urgent CT scan, contrast, IV contrast, then radiologists want ahead without a creatinine. So it is very important to have a creatinine. And also they will give, if you are entering correct data and the sample collection is correct, it will give you an estimated plasma volume as well. So I call this, I'm having a mini lab in my department. So what else, rather than these parameters, what else you need to manage your acutely ill patient, isn't it? Right. Very briefly. So there are different type of point of care testing. It could be a handheld devices, or maybe a portable, or maybe some benchtop devices, transportable one, or just a urine strip and HCG strip like disposable point of care test. When considering the areas of application of point of care testing, it could be a vast. I just mentioned few of here. In cardiovascular, respiratory, trauma with bleeding, infectious disease and sepsis, renal, there are many more. These are some of the tests which are available in Sri Lanka. There may be many more, but these are which I know to have. So one is the cardiac troponin and the BNP, lactate, blood gas, hemoglobin, coagulation test, ROTEM, which is very helpful in trauma patient. Otherwise, you give all the type of blood products. If you're having a ROTEM, you know what is wrong with the clotting cascade, and you can give the specific component. And the D-timers, electrolyte panel, creatinine and urea, as I mentioned before, and the blood glucose. If you're having a blood gas analyzer, you don't need to prick again to check the blood glucose level. And the ketone bodies. And when a patient coming with the toxics, recently we got a patient, she was, actually when coming to the emergency department, GC was 3. And only clue was pupils was pinpointed. Otherwise, previously healthy child cannot wake up. So because of the pupils were pinpointed, we manage as possible overload of opioid. And with the treatment, she was improving. But she was initially need intubation and recovered. but she was completely denial of any opioids. But her urine was positive for the opioids. Then the history was her aunt was taking some morphine tablets and she took overdose with the morphine because she used to take one tablet for her headache. Now I think maybe, we don't know the reason, she was completely denied, but she had a morphine overdose. So without having the urine test for the toxins and the substance, we couldn't able to make any diagnosis. Otherwise, we will investigate her for so many other possibilities for acute loss of consciousness and reduced GCS. So, and also the alcohol level, the pregnancy test is very important. Any female who are coming for any complaint, even headache, feeling not good, anything, just do the urine HCG. You are out of many problems, okay? And they are developing now different type of pathogen kits, and the urine full report also very important, especially not only to the diagnosed TI, but if you're having a patient with suspected colic, you don't know whether this is a colic, sometimes with the appendicitis or some cholecystitis. In that case, if you're having a report with high RBS compared to the white cell, then it is very useful. And also, as I mentioned, ultrasound is very important, and for the sepsis-wise, high sensitive CRP is now available, and the prolactin and the portable X-ray also, it's like a camera with a digital screen. It is available now, and these are some of the point of care testing available. And even though this is a big list, nowadays, because of the technology, they integrated most of the tests into one. So the issue, there is a good thing also, but the issue with that, now the chips are getting smaller and smaller, so there could be a problem with sensitivity and specificity when comparing to the lab report. And also, there is a concern of accuracy and reliability if the sample correction. For example, nowadays we are doing blood gases and we have to heparinize. We are using the sodium heparin. And if if you are thinking, there is more heparin, there won't be no clots, and you are leaving some heparin in the tube, it causes many errors in the sample. Therefore, when you are taking the sample, when you are doing it and analyzing the sample, there is a risk of errors if you are not doing it correctly. And also, any test can have an operator variability, and these tests are usually doing by emergency staff, or if it is in the ward staff. So you have to, most of the time, all the doctors and nurses has to know about the procedure. So the training will be a little bit challenging. And these, especially the blood gases, those kind of consumables come with the storage issues. So it has to be maintained the cold chain, and it having an expiry date. So we have to make sure these dates are correct and you are not using the expired samples. And also, when comparing to the central lab, the cost is a little bit higher. And the final thing is, when you are having the luxurious point of care testing in your department, it can be misused and overused. For example, when a child comes with the chest pain, you might doing a troponin for them as well. With a young adult coming with respiratory symptoms, maybe sounds like more pneumothorax or some upper respiratory tract, still they are doing a troponin. So misuse will be a problem. Okay. So do you think the point of care testing will replace the central lab when you are managing the emergency patient? Maybe. Maybe it's already happening, I think. So, come to the conclusion, the last part of my last slide of my presentation. So, as we already discussed, you can see now, when you are using the point of care testing while you are taking a proper history and examination, you can come to the most appropriate diagnosis. If you are making a most appropriate diagnosis, then you can start the target treatment rather than starting a cocktail of treatment, very specific treatment. It will reduce the mortality and the morbidity, but always use this test with the clinical sense, right? Without, you have to do a proper assessment before using the point of care testing. And there are many areas we can use it if I encourage you to do more and more research. That's all. Thank you for listening. So I think this is the last lecture. Do you have any questions? And I have no special interest or conflict of interest, but you can see there are a couple of stalls here with the point of care testing. If you have any doubts, you can go to them and ask. Okay, thank you.
Thank you very much, madam, for such a comprehensive lecture. I think all the questions were answered. To deliver the token of appreciation, I would like to invite Dr. Suranga Gamage, a consultant emergency physician, Colombo North Teaching Hospital. Thank you, madam. Thank you, sir. Ladies and gentlemen, what a day it has been. Today has been nothing short of inspiring, filled with valuable insights and shared commitment to advancing our understanding and practices. It has truly been a privilege to hear such distinguished speakers today, covering all aspects of medicine. At this moment, I would like to ask the audience to spend 2 minutes to give us a feedback through the displayed QR code on the screen. And note, we will be forwarding the e-certificate to your respective email addresses. Thank you very much. To formally conclude the session today, it is my honor to invite Dr. Dushyantha Goonewardene, Consultant Emergency Physician, Colombo South Teaching Hospital, to deliver the vote of thanks. On the same note, I invite you all to join for tea after the vote of thanks so we can connect and reflect. The tea will be served in the lobby. Thank you very much and hope to see you all at our next conference. Until then, stay inspired. Thank you.
Good evening, ladies and gentlemen. It is my great pleasure to deliver the vote of thanks this evening on behalf of EMSYM 2024 organizing team. First and foremost, I would like to thank our chief guest and keynote speaker, Dr. Abeyjeewa, for being with us today and inspiring us with his invaluable insights into management of dengue fever. A big thanks to our amazing EMSYM organizing team and the committee, which includes Dr. Indika, Dr. Inuka, and Dr. Chamindri, who was our co-chairperson. They did a Herculean task in organizing time of less than 1 month. A special thanks goes to the following people: Metmal and Asanka for the overall coordination, Lakmal and Upul for the AV audiovisual coordination, Lakita and Nisanki for the academic coordination, and all the other senior registrars who planned out and moderated the sessions. Erandi, Kaminda, and the team who organized the registration, which was an uphill task, as well as Leshara, Sandamali, and Prasanna for sorting out the correspondence. Suren and his team for sorting out the catering today. Piniru, Metmal, and the comparing team for the smooth introductions. And Ishanka and her team for the ushering. All that you have experienced today is the result of hard work, sleepless nights, and sacrifices made by each and every one of them. It is a great pleasure to have worked with such an amazing group of talented individuals and for their dedication. And this has made this program a roaring success. And of course, Dr. Samoda, a very special thanks goes out to you for all your hard work. All these beautiful graphics and media you saw here were the result of her amazing talent and dedication. I would also like to extend my deepest gratitude to the expert panelists and speakers of EMSYM 2024. The knowledge and expertise that you have shared today will be invaluable to all of us in improving and optimizing critical patient care. Thank you sincerely for taking the time from your busy schedules to make our event a success. And, of course, to the moderators, thank you all for your hard work in coordinating and putting together thought-provoking and interesting cases that were discussed here today. The time and effort that you have put into preparing the presentations is extremely valuable. You've done an excellent job in enriching our understanding of topics discussed. Of course, a big thank you goes to our event management team led by Mr. Kapila for making this event run smoothly and for entertaining all our requests with patience over the last few weeks. I would also like to thank our main sponsors, without whom this event would not have been possible. MQ Pharmaceuticals, the bags that you all are carrying home today were sponsored by them. Technomedics, ARS Healthcare, Biomedica Private Limited, Hemas Pharmaceuticals. Last but certainly not the least, I would like to thank all of you, ladies and gentlemen, for the enthusiasm and interest you have shown in this event. Your presence and engagement have made this event meaningful, and we hope that you found this session invaluable. Once again, thank you all for being here with us today, and we look forward to seeing you again at our next emergency medicine conference next year. Thank you, and good evening, and please proceed to enjoy your evening tea outside. Thank you very much.
There is one last announcement. Dr. Yasit Rodrigo, congratulations. You have won the Oppo raffle draw. Please visit the stall outside. Thank you.
So the manufacturing line here at Quidel Ortho is really truly state of the art. We manufacture the triage product line right here in San Diego, California.
Triage is a point of care device that allows a clinician to be able to test and help them diagnose a patient.
It's got the technology of a chemistry analyzer in a very small footprint.
Our manufacturing starts with a plastic base. Essentially, if you're walking down the line, you go from the solid phase, which is the markers we're trying to detect, to FETL, which is the fluorescence that we capture, to the filter, to the label, and then a finished good device.
We went from 2 manufacturing manual lines to now we have 3 automation lines and 1 manual line.
Since automation, we've been able to crank out upwards of 150,000 devices per day.
Automation makes sure that there is no variation in the devices that we build.
So you have people working on the lines trying to improve them, trying to adjust certain parameters to make sure we get the best product off the line. I think it goes back to our purpose, which is always trying to deliver the best product to improve patient health.
I feel like when you're working for medical devices and you know that the product that you're making has an impact, you take more accountability and you become more passionate about your everyday job.
Technomedics has been fueling the evolution of Sri Lanka's healthcare sector for over 2 decades. We are pioneers in the supply and installation of medical equipment, the design of healthcare facilities, and turnkey projects in Sri Lanka. Today, we are the leader in supplying world-class medical equipment, medical consumables, and turnkey solutions to hospitals across the country. And we are also at the forefront of medical aesthetics, saving lives through innovative technology.
Founded in Seattle, Washington, 1997, Oppo has become an international medical brand. As a global healthcare solution provider, Oppo applies innovative power to improve people's lives through a wide range of products to meet customer demands. Oppo implies...
Check, 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 test, check, 1, 1, check, test, check, test, check. Check, test, affected, check, 1, 1, 2, test,